ברוכים הבאים לשערי צדק. תודה רבה שהגעתם. מספר לנו יום עמוס ואני חושב מאוד מעניין. לעשות כנס על זה אני אומר בעברית בכוונה שאריק לא יבין, כי לעשות כנס על IBD אפשר להביא את מה שעשינו שנה שעברה, 300 איש הגיעו בקלות. לעשות כנס על אפידמיולוגיה, לא משנה מה, כבר אנשים נרדמים ולא מגיעים. והיות ואריק הוא אחד אולי האפידמיולוג של IBD הבולט בעולם, אחד משלושתם, אז זה צריך להגיד בעברית בשביל שהוא לא יבין, זה לא... חשבתי ככה. Okay, we'll switch to English. And the people who speak, if they're comfortable enough to speak in English, so that will be much appreciated. Although Eric is his name is Ben Shimol, it's his first visit to Israel, and we're very proud to have him here. This is a unique opportunity to get the representative from the four Kupot Cholim and representative from all major IBD centers in Israel in one room and to discuss epidemiology of IBD. So we discuss treatments and things, but truth is we have no idea, or we have no good clue how many patients we have in Israel, not to mention their trends and things, although there were quite good research done, Eran Israeli, Zohar, other people as well recently to have some approximation. We hear that in due time. I just asked the chairpersons to keep the times with the be harsh and strict with the lectures, so we are on time. Special thanks to Tamar, Malka, Gili, and Leah that are not here, that they put a lot of efforts in organizing this conference. Thank you very much. It was really a big effort, but I think it's going to be worth it. Thank you very much. And without any delay, I would like to ask Dr. Iris Dotan from Ichilov to give a few words and to introduce the first speaker.
Hi, good morning. It's a pleasure to be here today. I'm Iris Dotan from the Tel Aviv Medical Center, and I'm part of the Israeli IBD Research Network. I think this is a very unique opportunity for us today to discuss epidemiology of IBD. I don't think we have done this in this forum in the past in Israel, so thank you, Dan, for organizing this, and thank you, Eric, for being our distinguished speaker. I'd like to mention that the effort here is very unique, had never been done successfully in Israel, and I think that the contribution of all major IBD centers in Israel and all Kupot Cholim, so Klalit, Maccabi, Leumit, and Meuchedet, everyone is giving their share, and I think this is what will contribute significantly, and Dan's competence in leading this with major other IBD researchers in epidemiology from Israel. This is all, should be mentioned, supported by the Helmsley Charitable Trust, who is supporting Israeli collaborative research in IBD. And I think that without further ado, we should just mention the good intentions and the expertise of everyone sitting in this room and beyond it. And I'm sure that this project will be an extremely successful one, and we look forward to the results. Shomron Ben Chorin, you're the first speaker. Oh, you invited the chairs, Nati Lederman and Eran Matz from the Kupot Cholim, and they will invite you, Shomron, and then we'll have the pleasure of hearing you.
Okay, good morning, everyone. Pleasure to open this interesting meeting and to try to set the stage for the subsequent talks, by trying to comply with what Dan was asking to give an overview of what are the, what I would say, the hot topics or the new updates on IBD in 2013. And those of you who give talks, and most of you do, so you know this is a very tricky topic. So I do apologize for anyone whose favorite paper or favorite topic is not mentioned, because the scope is immense. But I did try to sort of putting into consideration both the heterogeneity of the topic and the heterogeneity of the audience, because we have here epidemiology experts from Kupot Cholim, and on the other hand, IBD experts, with some people interjecting between the two of them. But still, I mean, it's Dan was mentioning it might be a little bit of having to refer to both IBD experts and people who are familiar, but maybe not as familiar with the IBD. So I'll try to do my best with that. And another word of caution is that some vivid illustration may not be pleasant for all of you. So I'm glad you ate already, and I think I might save a little bit on the food for later, because some of you may not like to eat after that. So trying to say what is new, I sort of try to focus on a few words on pathogenesis, but not much, given the clinical focus of this meeting. But few words on what's new in 2013 in IBD pathogenesis, and then dwell much more on treatment and monitoring aspects, which I think are more relevant for our purpose. Pathogenesis, traditionally, we've been thinking about Crohn's disease and probably also ulcerative colitis as resulting from an excessive activation or inappropriate activation of intestinal immune system, which is a sort of a sum result of genetic background in a susceptible patient or individual, combined with some environmental insult, which are yet to be defined, possibly related to the microbiome or external bacteria, but possibly also related to some other polluants or dietary constituents, as well as some features of the immune response itself, which may be dysregulated in those particular susceptible individuals. And the outplay of this seems or is hypothesized to yield to the end result of IBD. Now, is it really a genetic disease? So we probably we all know about it, and we'll hear about a little bit or more about that, about IBD in Israel from the following speakers. But we do know there is an increased risk for IBD in family, and this is data from Israel. And we have those studies both for twin studies and families outside of Israel. We also know the original IBD genes that have been described almost 2 decades ago, starting with a famous NOD2 and thereafter several other genes. But this has now exploded with GWAS techniques to over 160 genetic loci, polymorphism and other mutation that have been associated with IBD. And this, in my mind, raises a question: are we really dealing with one disease? And again, I'm not going to go into the different genes and describe this. This is way too much for this for the scope of this talk. But I think this is an interesting concept to start thinking about: is it really one disease we're dealing with? Is it really one Crohn's disease, or are those different diseases that have some similarities in between them? Now, there are also environmental effects, as you're probably all aware of, and as has been very nicely seen by immigration studies of patients, for instance, from the Indian subcontinent, whereby when they migrate, for instance, to London, the second generation will suffer a similar prevalence of IBD as their Caucasian neighbors, whereas if they migrate to Eastern Asian countries such as Malaysia or Indonesia, which is another favorite place for Indian immigration, they will still have low prevalence and incidence of the disease, suggesting again that genetic background may be important, but there are certainly environmental factors which need to be defined playing a role in this in susceptibility for disease. Now, I've mentioned the microbiome, and if I would have started this could be a whole talk, but I will just mention that there is increasing evidence on the role of microbiome, and specifically some changes in the residing bacteria in the gut within the IBD population, and specifically the Crohn's disease population, as compared to healthy individuals. And more and more data is pouring out on this topic, and although it still remains to be translated into clinical practice and for prediction tools, as we will dwell on later on. And in summary for this pathogenesis, I think we're actually approaching very fast to what I call the meta era, whereby we're starting to deal with immense databases and immense bodies of data through metagenomics and metaproteomics, is just exemplified by one recent publication showing how metaproteomics combined with metagenomics and microbiome analysis sort of can start mapping different individuals with Crohn's disease of the colon versus Crohn's disease of the intestine versus healthy individual, and you see how those different groups of patient or individual cluster around these maps of both protein and genetic and microbiome phenotypes. So as I promised, this was a very short introduction on pathogenesis, and we'll now move on a little bit about treatment. And there have been certain changes in how we view treatment and monitoring in IBD, and I think this is a change that is occurring throughout medicine in general. And in particular, in IBD, we're starting to think about are we looking for the right target in treatment goals, and that means should we be seeking deep remission, and in achieving that will achieve possibly changing the natural history of disease, and we'll talk about that a little bit. We have new therapeutic modalities and agents, and also new therapeutics approaches stemming from them. And of course, the age of personalized therapy that we all talk about, but is actually making its first baby steps, I think, as we speak. So, for all of you who are acquainted with Crohn's disease, I think this is a blockbuster slide of IBD. This is showing how the phenotype of Crohn's disease changes over the years, whereby most patients who start out as an inflammatory luminal disease will eventually accumulate or transform themselves into the penetrating phenotype, whereby they suffer from complication of penetrating disease or stricturing, meaning stenosing disease. And just to say what is the end result of that, that usually culminates in a risk of surgery that, despite our most advances, it's still debatable, but probably has changed much, and goes around the 60 to 70% of patients that will eventually have at least one surgery, intestinal surgery, throughout their life for Crohn's disease. Now, to make things more vivid, especially for those in the audience who are not gastroenterologists, so when we talk about shift of pathogenesis, so clearly this patient, as you see their colons up on the upper panels compared to a healthy colon below, everyone can, you don't need to be an expert endoscopist to see how miserable those people will be with deep ulcerations. However, you do not see any strictures, and you do not, at least by this form, you don't see any penetrating disease. And the same goes for ileal disease, as you see here. And the problem we are facing is those patients, as I said, about 60 to 80% of patients will progress their disease, and rather than staying a luminal disease, which can be controlled, will progress to different complications. And this is, for instance, a dreaded complication of perianal disease, which is perianal abscess, which eventually can again culminate with recurrent drainage and fistula, as you can see on the right-hand side. I warned you about the pictures. You can't say I did not. So abdominal wall abscess, this is how it looks on another patient of mine. You can see, you can almost sort of feel the abscess below the abdominal wall, almost with imminent drainage, spontaneous drainage. And these are all the complications that we do not like. This is another patient with 6 fistula opening with Crohn's disease of the small bowel. So you can understand how those complications will change the quality of life of this patient, undoubtedly. Another phenotype that is transformed in transformation from the luminal disease is a bowel obstruction, or what we call fibrostenotic or stricturing disease, and this is how it again manifests itself in real life, in a real everyday clinical life. And you can see here the dilated bowel loops on abdominal X-ray, and here you see a colonic stricture and dilation for this patient. Thank God that we were able to dilate it endoscopically, but many of those patients will end up undergoing surgery. So again, this was some vivid illustration, I think, for this slide that we talk a lot about of it, but I think it actually translates into everyday people who move from this more controlled or controllable in principle phenotype to the more dreaded phenotype that we must do everything within our power to prevent. And indeed this concept is arising in recent years about this recurrent insult to the bowel leading to cumulative bowel damage, and has been proposed in a recent slide from the French group, but actually an international effort, to start looking at bowel damage as a cumulative process and start to quantitate it. There has been now a Lehman score for MRE, quantitation of damage of the bowel wall, and indeed this also transformed a little bit our thinking about the disease and our efforts towards preventing this cumulative bowel damage. But really the question then arises, can we by therapy alter this natural history, prevent this bowel damage, and prevent the subsequent complication and surgeries? And is this really related to early therapy? So there is, we'll just briefly review some data, and for the anti-TNF class of drugs, there has been some data presented in placebo-controlled trials showing that indeed the active arms are usually superior in the sense they can prevent surgeries as one outcome of looking of complication or a more severe progressing disease. And you can see that both for adalimumab, Humira, and also for infliximab, Remicade. But actually, we probably don't have to go so far because there has been some quite good data, although not from a placebo-controlled trial. But this is data from Hungary, from Peter Lakatos, and showing that early azathioprine use, in the sense of people who were started on Imuran, very early on throughout the course of the disease, you can see they benefited from this approach by having much less chances of surgery throughout up to 10 years later on. So this concept is again gaining support of trying to prevent surgeries, and the goal that we would seek throughout this more intensive therapy and perhaps earlier on is the second concept that has been aroused in the few recent years, which is mucosal healing. Because it is not really practical to treat a patient and to look whether or not we failed by having him going to surgery or developing complication. Rather, we want some surrogate marker to show us along the way how we are on the right track. And that appears to be probably mucosal healing. And it bears the reason that if you do achieve, and you can see it quite nicely on this slide, if you do achieve such a mucosa from previously so much healed mucosa, one, again, does not need to be an expert IBD to realize that the chances of later complication from this kind of mucosa or this kind of bowel is much less. And the question is, indeed, how good surrogate marker is it, and how should we achieve it? So, first of all, regarding how good a surrogate marker is it? So, indeed, some data, again, with this is again for Humira, for adalimumab, showing that patients that achieve deep remission, and in deep remission we usually mean we refer to the patient who are both symptomatically asymptomatic, but also enjoy biochemical, i.e. CRP or calprotectin in normal values, but also mucosal healing. And in those patients, you can see, although the numbers are admittedly low, but those patients who had this deep remission, including mucosal healing, had substantially less risk of both being hospitalized in this Humira trial, and also when looking in the Ipsen cohort, looking at mucosal healing, those patients have a much reduced risk of being operated on throughout the follow-up after up to 6 to 7 years. Now, can we really achieve mucosal healing? So again, this is data for the biologics, showing that indeed, for instance, in this SONIC trial of combination azathioprine and infliximab compared to monotherapy or azathioprine alone, and you can see indeed that this is an achievable goal, because 1 year later, at week 50, up to 55% of the patients on combo therapy were able to achieve this mucosal healing. But of course, for mucosal healing and for prevention of subsequent complication, we need effective drugs. And luckily for us, we're living in a decade where the arsenal is expanding very rapidly, almost every day. So we've learned that, for instance, in the recent years, that the importance of migration of lymphocytes into the inflamed tissue. And this slide, which is very nice, and I have to thank Professor Chawaz for it, shows you this process, which probably most of you are familiar with it. But this process also allows to identify some target molecules, most notable of which is the integrin alpha-4 beta-7, which is denoted up here, but also CCR9 and its ligand TESC, which are involved in mediating the transmigration of cells into the inflamed tissue of the gut specifically. And this has led to the development of anti-integrin therapy led by vedolizumab, anti-alpha-4 beta-7, but followed suit by several other biologics that are in different stages of development. But certainly for vedolizumab, the anti-alpha-4 beta-7 results have been very impressive, both for UC and Crohn's disease, and it has already undergoing a registration for use in the United States and starting elsewhere. We have also some novel therapies targeting other cytokines, such as ustekinumab, which has shown its effect, its benefit in Crohn's disease. And we have a very exciting drug, which actually is, I think, is a true breakthrough, and this is the tofacitinib, which is actually a small molecule rather than an immunoglobulin that is a JAK kinase inhibitor. And I just, again, we don't have the time to dwell on this, but I just outlined here that on top of other advantages that such therapies might have in the sense that they are orally taken, they do not arise immunogenicity, etc., etc., if you just look at on the percentage of remission with this drug, this is really striking, I think, to any one of us who deal with IBD. And you can see rather than 10% of patients entering remission, Mayo score remission, endoscopic remission with placebo, so the results with an active drug with only 8 weeks of therapy was almost 50%. And this is, I think, is unprecedented in any of the treatments that we are used to see in IBD. So I think the future does hold, even the present does hold a lot of promise for having more and more efficacious agents. Now, all this builds up to finding the right patient and the right timing. How do we stratify the patient for aggressive therapy and at what stage? So one such sort of scheme could be that we should target right from the outstart mild disease for either follow-up or maybe mild transient therapy with budesonide, etc., whereas those with moderate disease should be risk factored or stratified by risk factors and then receiving immunomodulators or even biologics. But this question really arises, probably the last part of this talk is a personalized medicine. Are really all patients at risk of complication, and do they all need this early intensive therapy? So this is a much dwelled with topic now in IBD, and stemming from data showing, for instance, and this is sort of the counter assertion, few tough years to begin with, but then we'll enjoy a very long remission regardless of any therapies. And certainly we would not like to treat aggressively those patients who will enjoy probably a benign course of disease regardless of what we do to them, and probably will do them harm by adverse events of drugs. And so this brings a question of how do we choose a patient, or how do we identify the patient who are likely to develop those complications that I showed you, the dreaded pictures beforehand. So prediction is actually is something that I think for epidemiologists maybe and clinicians to really combine hands in. And there's a lot of pitfalls in this, and one of them is that depending on how you define what is disabling disease or what is an adverse event, this is what the predefined criteria you will find. And it's very nicely exemplified by a study from France that was published last year, looking at a cohort of 309 patients. And then looking at this cohort, the authors, what they did was classify them according to different classification, what would be considered a severe disease that one would aspire to prevent. So, for instance, you can choose a definition that were coined by Laurent Bougerie of 2 steroid courses, disabling chronic symptoms, etc., or intestinal resection, or you can be more rigid and require complex perianal disease and colonic resection, or at least or more than small bowel resection, or even more rigid than that and more strict than that, and require or define your severe disease as gross failure. This was a pediatric cohort, and intestinal resection. And you can see that depending on how you define what is a severe disease outcome, your cohort, or your group or subgroup that is this patient that you would like to target for intensive disease shrinks along your definition. Not only that, when you then look at what were the predictors in this cohort for those outcomes, the predictors you can see are similar but not identical, and actually quite dissimilar for certain attributes are dissimilar between those subgroups, again, depending on how you define the severe outcome you want to prevent. So we have this, I think, really problem in rationalizing the prediction tools. And another aspect of personalized medicine, and for this will be the last part of the talk, is the monitoring and adjusting treatment individually. How am I doing on the time? I lost track, actually. I'm okay. Okay, he'll shout. So this is about monitoring and adjusting treatment. Not only do we want personalized medicine in the sense that we have to choose the right patient, we also want that once we embark on therapy, we want to monitor for the inflammatory indexes, and we want to monitor the drugs we give. And this is, again, a slide that became very familiar about, again, infliximab, and showing how, for instance, monitoring or looking for antibodies to infliximab and the levels of the drug are correlated with a requirement or for a second infusion or a flare of symptoms. And similar data also shown for a patient on scheduled therapy coming every 8 weeks for infliximab, again dependent on the level of the drug and antibodies to the drug. And this has been recently translated in a controlled trial from Denmark, looking, although in a small group of patients, can we indeed monitor the therapy by drug levels and decide patients who are flaring up, can we decide by some algorithm employing these drug levels on who should receive a dose intensification or those who may need other intervention. And this arm of algorithm-based intervention was compared to what many people would do anyway in most of those flaring patients, which is intensification, dose intensification blindly. And the results were quite interesting because actually there was no difference in efficacy, although I must say that personally I think it also has to do with a small number of per protocol treated patients, only 19 in the algorithm base. But even with those similar efficacy results, the cost reduction was very substantial, more than 5,000 euros less for patients treated by dosing monitoring. And we actually have some initial data, preliminary data, actually coming from a multi-center Israeli study that was conducted with the help of many of the people sitting here in the audience. And I'm just showing you one slide, for instance, again, showing that if you look for patients who are losing response and trying to decide what to do next. Do you want to really double the dose or do you want to do some other stuff? And if you try to gauge that by the titer of antibodies, anti-drug antibodies, you can see the difference in response between those who have low titer or no anti-drug antibodies versus those who have high titer antibodies to the drug in whom this intervention of dose intensification is quite futile. So this is bringing us closer, I think, to personalized medicine in the sense of monitoring the drugs we give. And indeed, just to bind it with a previous concept, this has recently been shown also to be correlated, the drug levels, with the mucosal healing, whereby the degree of change in infliximab after you dose intensify for a patient who was flaring up was the degree you can achieve adequate drug levels was correlated with the degree of mucosal healing when this was later looked upon in endoscopy. And I think the most vivid example of this drug monitoring is coming from the TAXIT study, which is quite complex, and we'll just go very briefly with it. But this study coming from Leuven looked on patients who are actually in maintenance therapy and seemingly doing okay, and then measured the drug levels. And we're not going to go into this complex algorithm, but just to say that in general, patients who were having sub-therapeutic doses as defined by the investigators, where the dose of infliximab was increased, although the patients were seemingly doing quite okay. And on the other hand, patients who were having above therapeutic levels, the dose was decreased. And the outcome, I think, is very interesting for this dose optimization in patients, which I remind you were doing quite well. Because before optimization, you can see the before and after optimization, and you can see the 69 patients who were optimized for Crohn's disease patients, you were actually, although they were sort of doing okay, you were actually achieving a much better control of disease, both symptomatically and in terms of biochemical control. And this was evident most only for the Crohn's disease, not for the UC, but the UC group was somewhat smaller. And on the other hand, again, when you monitor the drug much closer than we're used to, you're able to do dose reduction in those who are actually getting too much drug without losing anything in both clinical efficacy and biochemical control of the disease. So the primary outcome of this study actually failed because it was designed to answer what happens next after you dose optimize and follow the patient for 1 year. So I think not so much surprisingly that was not much different because you already dose optimize the patient. But even then, when the data is looked upon closely, you can see that those patients who are still monitored benefit in terms of less requirement for subsequent intervention. And again, for us all, cost is very important nowadays, and it's certainly something we have to bear in mind. So you can see there was no difference in the cost between, actually strikingly similar between the two groups. So, and indeed, the other aspect of that is even the story of story, which is a landmark study showing that we are able to stop biologic treatment in some patients who are doing well after a maintenance treatment for over 6 months with infliximab and azathioprine. But again, regarding personalized medicine, and to tie it up with a previous concept, those patients were actually could be stratified actually for a decision model to show who are the patients you could stop the drug safely, and you could do that in over 90% of patients with over 90% success in patients who are having both mucosal healing and actually based on drug levels and other parameters, you can identify those patients who can benefit from stopping of this biologic. So I think to summarize my last slide is IBD 2013. I think probably the main theme is moving towards personalized medicine, and it encompasses both the identification of the right patient for probably early intervention. I might say on a personal note that I think with distinguished people we have here on the audience, that many of which are part of this IBD network and the SHARE, I think this is an important part of the current SHARE task, is really identifying the right patient from several projects that are being run. And also for enhanced, we need this personalized medicine is all about enhanced prediction and monitoring of the drugs that we give, and this is again part of the task that our consortium is dealing with. And I think all of this is likely to reduce patient disability, surgeries, and possibly also bring better care to our patient. Thank you for your attention.
Okay, so it gives me much pleasure to introduce our next speaker, which is Professor Eric Ben-Shimol. Aside Eric being a good friend of mine and a colleague, he's done his residency in Canada and his fellowship in pediatric gastroenterology in the Hospital for Sick Children in Toronto. There he's done his PhD, and his PhD was directed into administrative databases in clinical epidemiology. And ever since, he's built to be one of the leading people in the world for epidemiology of IBD, not only in pediatric but adults as well. And he has some very important publications, including the meta-analysis of the epidemiology of IBD in Israel that we all know from IBD and gut publications. So he developed the algorithm, the search algorithm strategies to find IBD and the computerized databases of ISIS in Ontario, and now he's deeply involved in doing that in other parts of Canada as well and beyond. And we are very privileged to have Eric not only here today, but involved in our project of trying to validate and to find the algorithm, the best algorithm in the HMOs and in our hospitals as well during the last year and the 3 years to come. So with that, I think we are very interested to hear what you say, Eric. Thank you very much for coming.
So I've got my timer. I'll try to make sure that I'm running on time, but I want to thank the organizers of this meeting, and especially Dan Turner, for inviting me to speak to you. It really is an honor. It's my first time in Israel, if you can believe it, almost 40 years, and I haven't been here. But I think it's especially special that I can come here and visit at the same time as I come to speak to you about a topic that's really important to me in terms of children with inflammatory bowel disease and all the population with IBD. So it's sort of a dual honor that I'm here. And I do speak a little Hebrew, but it's after not using it in Canada for 20 years, most of it's gone, unfortunately. I think I remember more than I can speak. You guys can all hear me with the mic? It's okay? All right. So this talk is more about the IBD world. And I'll start with a few slides about Ottawa. Ottawa is the capital of Canada. If you can believe, Toronto is not the capital. It thinks it's the capital of Canada, but it's not. Ottawa has been the capital for a couple of hundred years now. And these are the Parliament buildings in Ottawa, and probably the image that you have of Canada and of Ottawa is snow all over the place, and particularly something like this. This is the Rideau Canal in Ottawa, where it freezes over in the wintertime, and people skate on the canal. And in fact, you can skate to work because the Rideau Canal runs all the way around Ottawa. So if you work at the Ottawa Hospital at one of the campuses and you live downtown, people can skate all the way out there. And in the background is the Chateau Laurier, which is one of the more famous hotels in Canada. But lest you think that it's all snow and igloos and everything else, we do have spring and we do have summer, and it gets very hot for us, 30 degrees, 32 degrees. This is at the Tulip Festival where they have tulips for about 3 weeks all over the city, and you see the Parliament buildings in the background. So we do have different seasons. It's not just snow and igloos and ice. And this is my hospital, the Children's Hospital of Eastern Ontario. It's about a 250-bed hospital, sort of a mid-sized hospital for Canada. There are 5 pediatric gastroenterologists, each with their own sort of area of expertise. And there are two people who specialize in IBD. We follow about 300 kids with IBD, and we diagnose between 40 and 50 a year, although this year so far we've already had 70. So we'll talk about the increasing rate of IBD, but certainly we're feeling it in the clinical world as well. So the objectives of this talk are firstly to understand the opportunities for IBD research using health administrative data and large databases, to review the changing epidemiology of pediatric IBD in Canada and worldwide, and to demonstrate that epidemiology research can give clues in the search for environmental contributors to IBD etiology, that it's not just esoteric that we're describing numbers, but it can actually lead to advances in our understanding of the disease. So I want to introduce a concept to you. So many of you know about this idea of translational research, where you take a scientific finding that you discover in the lab or on a bench, and you bring it to the bedside to try to make a change in the patient care. And that's sort of the older way of thinking of translational research. I like to think of a newer translational research, where not only do you take discoveries at the bench, bring it to the bedside, but you may take discoveries that use large databases in the health system or population-based databases, bring it back to the bench, and try to find the biologic plausibility behind them. So I'll give you some examples of where that's being done and where that could be done in the future. To give you an introduction about Ontario, Ontario is Canada's largest province. There's about 36 million people living in Canada, and 40% live in Ontario. So Ontario has a population of about 13.3 million people. 25% are children, and about 28% are born outside of Canada. So that makes Ontario fairly unique, that it's a very heterogeneous population, a lot of immigrants. The majority of the immigrants are from South Asia. That's the #1 immigration group, as well as China, Hong Kong, and the Caribbean is the 3rd largest. And Ontario has universal health care, which means all patients, all people, legal residents of the province have a health card number. All care is provided by the Ontario government and is paid for by the Ontario government, with the exception of prescriptions, where if you can afford it, you have private insurance for medications. But all other care is provided, inpatient, outpatients, procedures, and therefore all care is tracked within health administrative databases and tracked longitudinally within these data. In case you don't know where Ontario is, so we all recognize the United States. You can't forget where that is. It's sort of in the middle of Canada, central Canada. Ottawa is in the east part, near Quebec, and Toronto is down here near New York State. About 90% of the Ontario population lives along the border with the United States. So I'm going to talk to you a little bit about the Ontario Crohn's and Colitis Cohort, which the first publication was published in Gut in 2009. It's a population-based surveillance cohort using administrative data, which first tracked everybody with pediatric onset IBD, so children with IBD in the province, and now has been expanded to include adults and elderly patients. So the Ontario Crohn's and Colitis Cohort uses a validated algorithm to identify patients with IBD, and we'll talk more about the validation of the algorithm in my second talk. I'm going to stick more with the clinical and epi parts in this talk, but we'll talk about the methods that we use to identify patients. But the algorithm was applied to the health administrative data to identify all patients with IBD diagnosed under 18, and for the gut study it was between 91 and 2005. And for this study, we described trends in incidence and prevalence over time of pediatric onset IBD. We found that at any one given time, there were about 1,700 children living with IBD under the age of 18 in Ontario, and that we were diagnosing about 300 new cases per year. An update of the data has found that we're now diagnosing about 400 new cases per year in Ontario. We also found that the crude prevalence of pediatric IBD has increased by about 50% between 91 and 95. And you can see here the age and sex standardized prevalence changes in Ontario. The dotted lines represent 95% confidence intervals, and you can see that the prevalence increased from about 40 per 100,000 to about almost 60 per 100,000. Found that there was a significant rise in the rate of incidence of IBD, so incidence meaning new cases diagnosed every year, with the p-value of less than 0.001. But you can see that the incidence seems to be starting to rise in about 2001, 2002. And at the time, we weren't sure whether this might just be statistical anomaly. You know, we didn't have a lot of years of data after that. So could this just have been an anomaly that was happening? And we weren't sure what was going on at that time. More recently, we presented an update to the data at NASPGHAN this year, just about 3-4 weeks ago, I guess it was. And we updated the data to about 2009. And clearly, after 2001, 2002, there was a significant rise. The purple line here in the middle is the overall rate of pediatric IBD, and each of the other colors is different age groups, with the highest being 15 to 17-year-olds, not surprisingly. But clearly, there's a persistent increase in the incidence of IBD after about 2001, 2002, right up until 2009. Looking at different age groups, we found that in the gut study in 2009, the only age groups that were statistically significantly increasing in the rate of new diagnoses were children under 10 years old. So in children 0 to 4, the rate was increasing by about 5% per year, and in children 5 to 9, the rate was increasing by about 7.6% per year, but the rate in pre-adolescents and adolescents were relatively stable. However, with the more recent update, we're finding a bit different. So yes, the children under 10 were increasing most significantly, most quickly. So you can see that there was a 60% increase between 94 and 2009 in children 5 to 9, about a 56% increase, although not statistically significant anymore, in the 6 months to 4-year-olds. However, in the pre-adolescent and adolescent groups, while it wasn't as fast an increase, it was increasing as well. Not only that, the increase was not only due to Crohn's disease anymore, there was a statistically significant increase in ulcerative colitis as well. So across the board, increases in the rate of new diagnoses in children in Ontario. So how do our numbers compare to the rest of the world? We wanted to answer that question with a systematic review. So we conducted a systematic review of all the population-based literature. So we looked for only studies that contained all cases of IBD within a given jurisdiction, focusing on the incidence studies. And basically what we found, this is the map of the world for pediatric IBD, for pediatric Crohn's disease. You can see, firstly, one important finding is that there's a lot of white there, meaning there are a lot of nations who have not described their population-based rates of IBD, of pediatric IBD. But the darker the color on this map, the higher the incidence in terms of incidence quintile. And Canada is described as having one of the highest incidence of Crohn's anywhere in the world. And same with ulcerative colitis. It has one of the highest incidence of ulcerative colitis anywhere in the world. So this confirmed some adult studies that we had in Canada, that Canada has an exceptionally high rate. And if you looked at those studies in the systematic review describing trends over time, you can see that for Crohn's disease, there was a clear trend towards an increased incidence of Crohn's, whereas ulcerative colitis was a little bit more uncertain. It was sort of all over the place, stable, increases, decreases. So it was uncertain as to whether ulcerative colitis was increasing. What about adults? I don't want to leave out adults, even though my bias is obviously towards children. We also conducted a systematic review of the adult-based literature in coordination with a group in Calgary led by Gil Kaplan. Another systematic review of very similar methods, focusing on the diagnoses above the age of 18. And they also described an increased incidence in Crohn's disease. Obviously, there's a lot more studies that have focused, population-based studies that have focused on adults. And ulcerative colitis was, again, a bit more uncertain. So knowing that the rate is increasing worldwide, we wanted to look at the incidence of adults and children and compare them in Ontario. And these are data that haven't been published yet, but I'm just going to get out there hopefully in the next month or so. That, again, when you look at the data, increases in children by decade, 0 to 9-year-olds are increasing significantly, 10 to 19-year-olds are increasing significantly for IBD, for Crohn's disease, and for ulcerative colitis. So you can see a clear trend towards increasing incidence in pediatrics, but what's different in Ontario, which I don't think has been described anywhere else in the world, is that we're seeing a clear trend, very statistically significant results, of decreasing incidence in adults, especially adults aged 20 to 40, so the young adult group. All the adult groups, or most of the adult groups, are decreasing, but not statistically significant with Poisson regression. So there's something going on in the adult group compared to the pediatric group. Likelihood is, yeah, you mentioned it, so a shifting to earlier diagnosis, and that likely has something to do with better access to care in Ontario. We described in another study that there was a tripling of the rate of pediatric gastroenterologists in Ontario over the last 15 years. So it's likely that the children have better access to pediatric GIs, have better access to endoscopy, and so the rate of misdiagnoses are decreasing. However, it doesn't really explain this increase in the very young group. I find it hard to believe that, patients who have the disease from 7 or 8 years old are living for 20 years and not being diagnosed, or were living for 20 years. So it may also be that the onset of the disease has decreased, and that's an answer that we have to, it's a question we have to answer in the future. So the question is, thinking back to our incidence graph, that something happened around the year 2000, 2001 that caused an increase in the incidence of pediatric IBD in the province. We want to start looking at what exactly is going on in the province that has resulted in this sudden rise in pediatric IBD. And you saw this Venn diagram before in a different format. Basically, that we think that that IBD is the mix of a genetically susceptible host who's exposed to certain environmental risk factors or environmental triggers, and then develops a dysregulated immune response. And you need all three of these factors in order to develop the disease. So firstly, let's look at what happened after 2000 in terms of genetics. Well, genetics complex in IBD. There's over 160 different genes associated with IBD that increase your risk of developing IBD, but the vast majority of these genes increase your risk only a very, very small amount. And most of the genes overlap between pediatric and adult cohorts. So, what would cause an increase genetically, what change genetically would cause an increase in children but a decrease in young adults? It's really not clear because there's a lot of overlap in the genes. What recent changes may have happened to genetics in Ontario? Well, we didn't have any nuclear power accidents in Ontario. There's no mutant fish that we have. So certainly nothing like that. But I think the one change that may have occurred in Ontario in the last 10, 20 years was a change in immigration risk factors, so in immigration populations. So while previously in the 80s and early 90s, the #1 immigrant group to Canada were people from Hong Kong, not so much mainland China, but mostly Hong Kong. That has changed. More recently, the #1 by far immigrant group are people from South Asia. And most of our people from South Asia are from either India, Pakistan, or Sri Lanka. So does that give us an indication as to changing genetic risk in the province? Well, the map that I showed you earlier of pediatric IBD doesn't really say much because there's no population-based studies of pediatric IBD coming from the India subcontinent. Same with the adult studies. This is the map from the Molodecki article, the adult systematic review. And there is one study of Crohn's disease in Sri Lanka, which showed a very, very low rate of IBD. But there have been some good population-based studies coming from the India subcontinent. This study by Sood et al. Actually went to house in northern Punjab region of India and conducted house-to-house surveys, and anybody who said that they had any symptoms of ulcerative colitis, so bloody diarrhea, were scoped. So they actually did a flexible sigmoidoscopy on every patient who had any symptoms. So a very thorough study that you probably wouldn't get by ethics in, I don't know about Israel, but in North America we wouldn't be able to do that. But they found that the crude incidence of ulcerative colitis was about 6 in 100,000. Compare that to the study that you mentioned earlier from the UK, which found that immigrants to the UK, primarily from Bangladesh, had an incidence of ulcerative colitis of about 17 per 100,000, much higher than patients who were not from South Asia of about 7 per 100,000. So it seemed like in the UK, in this very small study, that people from South Asia had a higher incidence of ulcerative colitis when they arrived to the UK. Similarly, there was a study conducted from Vancouver that looked at the South Asian population in Vancouver and found that the South Asian incidence of pediatric IBD was about 15 per 100,000, higher than the non-South Asian non-South Asian incidence, so Caucasian patients, of about 5 per 100,000. A few caveats for this. So this non-South Asian incidence was quite a bit lower than what we've described in other provinces in Canada. Not sure why. Additionally, this wasn't a population-based study. This was really a single-center study, Vancouver, British Columbia on the West Coast. So what we wanted to do is we wanted to look at, in terms of population-based literature, what's happening in this South Asian group to try to describe any changes in the migration patterns and the risk of IBD associated with exposure to the Canadian environment. And so we linked the Ontario Crohn's and Colitis cohort to other health administrative databases, but also to the landed immigrant data set that we have available in Ontario. So we have available all the records of all immigrants to Ontario after 1985, and it's quite complete data with the date of their landing, where they came from, country of birth, and also country of citizenship, and some demographic information like education of the parents, education of the immigrants, socioeconomic status, income, where they landed in terms of where they were living. So quite complete data, and we were able to link the health administrative data to the landed immigrant data set using probabilistic matching. We also have the mom-baby database, which available in Ontario, which contains the records of all children born in hospital in Ontario, which is more than 98% of children. And those records are able to be linked to the mothers. So you can link the mother's records to the child, and therefore, if the mother was an immigrant, you can link the records to the child who was born in Canada as well. And so we wanted to describe the incidence and prevalence of IBD in South Asian immigrants, as well as their Canadian-born children. And by South Asia, we use the World Health definition for South Asia. Again, primarily in Ontario, that means India, Pakistan, and Sri Lanka. Those are the main countries where they come from. But the World Health Organization also, the World Bank definition, I should say. It's an economic definition. It also includes Bangladesh, Nepal, Afghanistan, what they define as South Asia. So it's a genetically very heterogeneous group. And so these are the numbers of pediatric IBD. So these were children who immigrated to Canada, to Ontario, who developed IBD under the age of 18. And you can see that we have a large population of children who immigrated from South Asia, about 100,000, compared to 370,000 children from other regions, and 4.5 million children who were not immigrants. The relative incidence ratio, that means the risk of developing IBD once you arrive to Canada, was about half of the non-immigrant population in both South Asians and in non-South Asian immigrants. Again, remembering that the non-South Asian immigrants were primarily from China, Hong Kong, and the Caribbean. Those were the main groups, although it was very, very heterogeneous. So the risk of developing IBD in the children who immigrate was about half the risk of children who are not immigrants. Similarly, for adult onset IBD, so these were people who immigrated and then developed IBD in the adult years above the age of 18, the risk was even lower, so about a third of the risk of developing IBD compared to non-immigrants. However, when the children, we looked at the children of South Asian mothers, so we only are able to link mothers to child. We can't deal with the fathers. The fathers are not important anyway, but they are important, I'm joking. But in terms of our data, we can only link mother to child. The children of women who immigrated from South Asia, so the Canadian-born children of women who immigrated to South Asia, you can see that the risk of developing pediatric IBD in the children born in Canada was the same as in the children of non-immigrants, so second-generation Canadians. However, the risk in immigrants from other regions remained low. So there's something about being born in Canada that triggers a risk in people from South Asia, early life exposure to the Canadian environment, that doesn't trigger that same risk in immigrants from other regions. So we found that South Asian immigrants had a lower incidence of IBD than native-born Canadians, and that the incidence of pediatric IBD in children of South Asian immigrants was similar, however, to native-born Canadians. Interesting that we also found this in asthma. So we've looked at asthma and type 1 diabetes, and we found that the risk of asthma, incident asthma, new diagnosis asthma, in South Asian immigrant children was about 66%, 2/3 the risk of non-immigrants. However, the children of South Asian immigrants had a higher risk, statistically significantly higher risk of developing asthma if they were born in Canada. The difference between asthma and IBD, though, is that this increased risk of asthma was also seen in immigrants from other regions, not in just South Asian immigrants. So clearly there's something about the Canadian environment, and with asthma and atopy you start to think about the hygiene hypothesis that is changing the risk of asthma in South Asians and non-South Asians. So what are we going to do from here? We're going to look at what age at immigration does this risk get triggered? So if you immigrate younger to Canada, does that confer a higher risk than if you immigrate older in childhood? What about immigrants from other regions? We're obviously looking at all of other regions across the country. And we also want to look at issues of health services where we want to know, is this an issue of access to care? Do they have as good outcomes? Do they have different clinical outcomes and different diagnostic delay? We've also started collaborating with the Canadian Children IBD Network, which is a new inception cohort in Canada, which aims to track all new diagnoses in Canada from a clinical standpoint from all the IBD centers across the country. It's a $5 million project that will look at not just clinical factors and health services factors, but at biologic factors. The plan is to administer an environmental risk questionnaire to all of these patients from South Asia compared to non-South Asian patients, and do whole exome sequencing, RNA sequencing, and especially the microbiome to see what's different about these patients from South Asia. And they're really focusing on the South Asian population in Toronto and Vancouver, where most of these patients settled. So this is, again, something that we've described in population-based studies that now we're bringing back to the bench and to the bedside to try to get more answers as to why this is happening. Just for your interest, I pulled the data on immigrants from Israel to Canada who moved to Canada and landed there. So we actually have about 10,000 immigrants in Ontario from Israel, so much, much smaller numbers compared to the immigrants from South Asia. But in terms of risk, just a caution that the 95% confidence intervals are very wide, especially for the pediatric group. But you can see that for the pediatric incidence, the incidence of developing IBD after arrival to Canada was about 25 per 100,000, compared to the non-immigrant population of 10 per 100,000. And when you look at adult Israeli immigrants to Canada, almost 50 per 100,000, compared to half that rate in Canadians who were born in Canada. So not a particular surprise to me. Again, Ashkenazi Jewish, all those genes that we share that increase your risk of developing IBD, it sort of confirms our idea of the risk in Jews. So moving on, genetic susceptibility may be a candidate for why the incidence is increasing, but I'm not sure that those small numbers are accounting for the increase. So what about environmental triggers? What's going on in Canada in the environment which may predispose to a higher risk of developing IBD? So there have been a lot of different environmental triggers that are out there and have been described in the literature. The most classic environmental trigger that we have is smoking, and that's the one that has been most well confirmed, that people who smoke have a higher risk of developing Crohn's disease specifically than people who don't smoke. But there have been all sorts of things that have been postulated: diet, medication, specifically antibiotic use, which we'll talk about in a second, appendectomy, which has been demonstrated potentially to have a protective effect against ulcerative colitis, exposure to farm animals, which we'll talk a little bit about in a second, and microbes and the microbiome, which probably plays a more central role than what I demonstrate in this slide. But we did look at all the different environmental factors. We tried to do a very complete literature review of all the different environmental factors that have been associated with IBD in the pediatric population, and this was recently published in this current gastroenterology reports. But I just want to demonstrate to you the table 1, which was a review, sort of a summary of all the, you don't need to read this, it's not meant to be read, it's very small type, I know. It really is a summary of all the studies that have looked at pediatric environmental risks of developing IBD. And this table 1, you can see all the different factors here and all the different publications. This table 1 actually goes on for 3 pages. So there's a lot in the literature about environmental risk factors, and many studies that are weaker than others, obviously. But I think the key here is to try to focus. And the focus that we have in pediatric IBD is the focus on early life exposure. So the thought is that your early life exposures are what changes your microbiome. So lots of things have been demonstrated, that breastfeeding, that exposure to certain environment, that malnutrition changes your microbiome. And for the most part, the changes in the first 2 years of life are permanent changes that sets your microbiome in it for your entire life. And so there have been a number of studies that came out of Canadian admin data, Canadian population-based databases, that looked at what early life exposures increase your risk of developing IBD, and I'll go through a couple of them now. But I think the key here is to try to define what is the point of greatest risk. At what age do your exposures define when you develop IBD? And if we know that age, we can start to study the microbiome. We can start to study what's going on in that patient's body from a biologic point of view to try to find the cause or the changes or the multiple causes, most likely, of the disease, and therefore try to target treatments and also try to target preventative treatments, so things that we can do to prevent the increase in IBD and Crohn's. What change occurs in those patients at that time? And what's the biologic plausibility, which is probably the most important factor. So antibiotic use, the first study that looked at antibiotic use in early life came out of Manitoba in Canada, which used their population-based case control cohort. So they have a large group of survey patients that they follow clinically that are then linked to the health administrative data to follow them through the healthcare system as well. So they have some clinical and some survey information, as well as all the health services utilization information. And they looked at the risk of developing IBD between 1996 and 2008 if you used antibiotics in the first 2 years of life. And the reason they use 96 as the cutoff, the early cutoff, is because that's really when the medication data in Manitoba started being collected. Before that, it wasn't collected. And I mentioned to you that Ontario, while we have a much bigger population than Manitoba, the medications are not funded by the government, and therefore we don't have access to good medication information in children. But they looked at the antibiotic use rate in 0 to 2-year-olds, and looked at onset of IBD between 2 and 12 years old. And what they found was very interesting, that if a child used antibiotics in the first 2 years of life, their odds of developing IBD before the age of 12 was almost 3 times the odds in people who did not use antibiotics. And particularly, the risk of Crohn's was about 5 times those who did not use antibiotics in the first 2 years of life. So, very wide confidence intervals again, but statistically significant that your risk is higher if you used antibiotics early in life. So the question that comes to mind clearly is what changes occur in the microbiome that we're causing with antibiotic use. They then wanted to confirm this, and so again, remembering that they only had medication information from 96 onwards, they looked at their data with the proxy for medication use, looking at diagnoses for otitis media. So in Canada, really until very recently, we were using antibiotics for everybody who was diagnosed with otitis media, every child who was diagnosed with otitis media. More recently, with the AAP statement changes and the Canadian Pediatric Statement, we've stopped doing that. But up till 2008, I think it's valid to use otitis media as a proxy for exposure to antibiotics. And because they had the longer time frame, they could look at IBD onset below the age of 19 years old. And this time when they looked, the confidence intervals were more narrow, but the trends remained the same in IBD. So if you used, if you had otitis media diagnosed in the first year of life, your odds ratio was about 2.7 compared to if you didn't. So if you got antibiotics, your odds ratio was almost 3 times compared to if you didn't. Same if you got antibiotics within the first 5 years of life. But this time they were adequately powered to show that this trend occurs not just in Crohn's disease, but also in ulcerative colitis. So your risk of developing IBD overall, no matter what type, was higher if you got antibiotics in the first 5 years of life. Let's move on to another risk factor that's been demonstrated using health admin data and population-based databases. So this group, led by Gil Kaplan in Calgary, used the UK THIN database, which is similar to the GPRD, the General Practitioner Research Database, which is really a population-based survey study of the practices of many, many different general practitioners across the UK. Directly from their clinic and their electronic health record. The THIN database is a little bit less complete than the GPRD, but very similarly structured. So they took 367 Crohn's patients and conducted a case control matched study to non-Crohn's controls. And what they found was that overall, there was no increased risk of developing Crohn's if you lived in a region of higher pollution, air pollution. However, if you lived in a region below the age of 23 and developed Crohn's as basically pediatric onset Crohn's, your risk was 2.3 times if you lived in a region with higher nitric dioxide levels. Similarly, if you lived in a region between the ages of 44 and 57 with higher NO2 and particulate matter, so higher air pollution levels, you are actually protected against the development of Crohn's. So this just speaks, it's a bit conflicting results, but you can understand that this kind of speaks to that this may not be an overall IBD thing, that there may be age-specific effects of different environmental risk factors, and we really need to start focusing on different age groups in order to identify these effects. And that's where Dr. Kaplan really took this to the new translational research method, where he described this population-based finding, and he took it to his colleagues at the University of Calgary and wanted to look at it at the bench level, at the basic biology level. So what's the biologic plausibility of what role the air pollutant would have on the development of IBD? And so this group from University of Calgary took it to the bench to a mouse model and found that when you fed the mice particulate matter, they had an increased secretion overall of different pro-inflammatory cytokines, IL-1 beta, IL-8, IL-12, and TNF-alpha when you looked at their intestine cross-sectionally. As well, when you took IL-10 knockout mice, which are one of the models for IBD who respond very badly to things like DSS, who have very severe colitis, the IL-10 knockout mice had an increased response in IL-17. So again, related to that Th17 pathway of Crohn's disease, you had a bad response if you fed them particulate matter. And there was also, when they looked at the microbiome, decreased microbial diversity and changes in the microbiome when you fed them particulate matter. So this sort of, again, brings the findings back to a more biologic plausibility level where exposure to these air pollutants, now these mice were fed, so it's not exactly inhaled exposure, but it's exposure in some way. The gut is being exposed. Exposure to these air pollutants changed the balance of the microbiome and also changed the risk of response to inflammatory triggers in these mice. Doesn't really explain why the risk is, it explains why the risk is higher in the child group. Doesn't really explain why there's a protective effect in the adult group. But I think it's a first step to sort of defining a biologic mechanism. So what about rural and urban environment? There have been a few studies that have looked at this. Firstly, again, from Manitoba with their population-based databases, they linked their questionnaires to their health administrative data and found that overall, if you lived in a rural environment as opposed to an urban environment at the time of diagnosis, there was really no significant difference in the risk of developing Crohn's disease. However, if you ever lived on a farm, meaning not at the time of diagnosis, but at any point in your life, you are protected against the development of Crohn's disease with an odds ratio of 0.62. Again, focusing that these are probably age-specific exposures, and we really need to look at specific age groups in order to identify the cause of these environmental risk factors. This was later confirmed to a certain extent by a study from Germany that, again, was questionnaire-based, not really population-based. But they found specifically that if you were exposed to farm animals in the first year of your life, as opposed to later in your life, that your risk of developing both Crohn's and ulcerative colitis was lower. So again, early life exposure may be the important time when we establish our microbiome and where we need to look with all of these database research and biologic research in order to identify the environmental triggers. There has been, again from Gil Kaplan's group, a systematic review and meta-analysis of the risk of living in an urban environment as opposed to the risk of living in a rural environment. For Crohn's disease, again, a lot of studies that have looked at rural versus urban, not necessarily population-based. But for Crohn's disease, the pooled odds ratio showed that if you lived in an urban environment, you had a higher risk of developing Crohn's disease. For ulcerative colitis, there was a higher risk. It was statistically significant, but not quite as high as with Crohn's disease. So now we're at the point of, in Canada, what can we add to this large body of literature? And the reality is that each of those studies that I showed you in the systematic review defined rurality different. And just in Canada, this Statistics Canada report defined rurality in 8 to 10 different ways. So there are many different definitions of rurality, and we have the power in Canada with our large numbers and our big databases to look at which definition of rurality really predicts your risk of developing IBD. And so that's really what we're doing as part of the first study from the CanGeek consortium. So yes, geek as in data geeks, and that's what we call each other. This is the Canadian Gastrointestinal Epidemiology Consortium, and this is really, you know, knowing that the databases in Canada are provincial because the health systems are managed provincially. There hasn't been a consortium of researchers who work together to produce national level data. And so we've now gotten together in 6 or 7 different provinces now, researchers in GI, not just IBD, but GI in general, who want to pool their data and look at more rare outcomes that maybe one province couldn't look at. And this is the first study of what we're doing, a national study of provincial administrative data. And we're going to be basically using meta-analysis techniques of observational research to look at national level risk. And that's something that you can consider here with the 4 Kupat Cholim. You don't necessarily need to link all the data because for privacy reasons, we can't share data, individualized data across provinces, but we can share pooled data. So we're going to meta-analyze the pooled data instead. We're going to look at different definitions of rurality and what age is the risk established for development of IBD when you live in an urban environment. We'll also look at disparities in outcomes and whether people in rural areas have worse access to care and worse outcomes. So in conclusion, my main message here is that it's my belief that translational research is not just bench to bedside anymore. It also encompasses this healthcare system model, and the population-based databases play an extremely important role in that. These population-based databases can describe what's happening and generate important hypotheses that can then be brought back to the bench to find the causes of these diseases. And I believe that the future of research are cohesive teams of bench, bedside, clinical researchers, health services researchers, and population health researchers, which will go towards finding the causes and improving the care of these patients with IBD. I'd like to thank all the collaborators. There's a whole list of them here, and then the funders that are shown here as well. And again, thank you for your attention and your time in inviting me to speak. Yeah, so I think there's going to be a lot of work going into that in Canada soon. I think what we're going to see is an increasing risk in immigrants themselves. I think that's firstly as the countries there become more westernized. We are starting to look, we're hoping to start to look at diet and whether diet is playing a role, particularly do the people who have a more traditional diet have a lower risk of developing IBD than people who have a more westernized diet. In Canada, I think it's a bit difficult because typically the immigrants to Canada tend to keep their diet and their lifestyle, and the children tend to keep the traditional diet as well until they become teenagers. Just, by speaking with the patients, that's kind of what I've learned. It doesn't really explain, diet doesn't completely explain this increase in children born in Canada because probably it's more, the diet evolves over time. So there may be other factors here, and again, it may be cleanliness. South Asia is very heterogeneous, right? You've got many, many different ethnic subpopulations. You've got many different diets, and you've got a varying difference in development in cities and in the country there. More antibiotic use, more modern medicine compared to, let's say, rural areas. So unfortunately, I don't think we have the numbers to look at every different risk. But I think there's going to be more work going into it, and I think the key here is then bringing our information and taking it to South Asia and looking at the risk factors in those populations as well. So I think you're going to see more and more coming out of that group of patients soon. So it's about 1 in 200 in Canada. Yeah. 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 Yeah, no, absolutely. And I think, yeah, so again, the map and the systematic review was really on incidence more than it was on prevalence, but I'm aware of that study. And I'm not surprised. I mean, I think, again, genetic risk of Israeli is probably much higher than genetic risk of Canadian who arrives primarily of Scotland and England origin. So I think that's probably what you're seeing, is that the overall risk to Israelis is higher because of that risk in Ashkenazi Jews and maybe in Sephardic Jews as well.
Was the denominator the same? So was that 100,000 children or 100,000?
18. Prevalence at 18, in 18-year-old cross. Point prevalence.
General prevalence or children?
So my prevalence was children.
Yes.
18. Yeah. Under 18, yeah. So point prevalence under 18.
What you were saying was something to do with socioeconomic status, perhaps those in the higher socioeconomic conditions were getting more antibiotics?
Yeah, and well,
or is it a direct effect?
So we have shown in Ontario that the risk is higher in higher socioeconomic patients, that we always control for that. Manitoba, as far as I know, did not control for that. But in fact, what's been demonstrated in Canada is that it's the lower socioeconomic status patients who seek medical care more often and are more likely to get antibiotics. So it's the opposite, right? Universal health care, it's not like America where lower socioeconomic status patients don't go see doctors because of the cost. In Canada, they use the emergency room more, they use walk-in clinics more, they use the hospital more, and they're more likely to get antibiotics for colds and coughs and flus. So it may be an indirect effect. It's hard to say. The Manitoba study didn't control for that.
Do you have any data on phenotype of disease? Because as Sharon alluded to, there's a difference. You showed at this presentation between colitis and ileitis. There's a Belgian trial, but gene arrays from Marcus showing that colitis and ileitis differ, and it might give a clue to the pathogenesis.
Yeah, so I don't have any data that's published, and the disadvantage of using this health admin data we'll talk about later is that there's no clinical information available in it. I think the key and the future is linked clinical with health administrative data. So with this the CanKids Canadian Child IBD Network, we will be linking all the clinical and genetic information that we collect to the health administrative data. So we'll be able to look at ethnic differences in the patients and differences in phenotype, but also look at whether those genetic and phenotypic differences predispose people to different outcomes later, even after they transition to adult care. So I think that's the future that we just haven't gotten there yet, unfortunately.
I think that it's time to let Professor Valentin present this.
I'm happy to take questions afterwards, but thank you very much.
Self-introduced. Hi, so it's a pleasure to be here. Thank you, Dan, for inviting me, and thank you all for having me in this talk now. What I will try to do in the coming half an hour would be to really briefly try to go up a few floors higher to 10,000 feet above the IBD domain, try to take a look at the broader aspects of chronic illnesses, about data-driven policy. As you will see, I come from Clalit. I have two roles there. I direct the Health Policy Planning Department, the Chief Physician's Office, where we do strategic planning, and the Clalit Research Institute that I'll describe in further extent as we go along. So we've seen the issue of the questions whether or not we have an increase or not. Do we have an increase in chronic, in different types of chronic diseases mentioned today, mainly IBD. But the problem is far beyond the specific issue of the gastrointestinal arena. Now, as you can see here, we're moving into an era where multimorbidity, chronic multimorbidity is becoming the norm. If there's anyone in this room that's above the age of 45, then you might be interested to know that over 50% of the people above the age of 45, at least within Clalit, are multimorbid, which means they have more than one chronic illness. And when you talk about over the age of 65, then it's 3 out of 4. So the question, if you don't know that you are multimorbid, two options: either you're in the, as my children say, the smaller half, or that you are you have not bothered checking properly. Yes. Or maybe that you're not in Clalit. Yes, which also, by the way, is a risk factor for that. Yes, I agree. So as we look at the data, and if you look at the literature in the last few years, you'll see that indeed the most common chronic disease that we have today is actually a disease called multimorbidity. That's the most common chronic disease. Now, rates are going just increasing as far as our data shows. And you can see that there's a classic Pareto law here that a small percentage of the population takes account of the vast majority of the resources. And if you'll take a look again, just to show you a little more data, just to understand, when we talk about the fairly healthy age of 45 to 64, when you take the patients that you see in this hospital, you probably see patients with an average of 4 different chronic diseases. And I'm talking about the young people that you see. When you talk about the older people, we're going far higher. If we take an average patient in Clalit with a disease called chronic heart failure, CHF, then this patient has, on average, or in median in this case, 6 other different illnesses. So there's no real IBD patient or CHF patient. It's a complex array of chronic illnesses that we have to take care of at once. And this is something that, especially when you are in a specialty, in a subspecialty, you tend to see the whole in the patient rather than the other option. And here you can see that the problem really goes beyond just one domain. So rapidly aging population is another issue that we are now withstanding. You probably know that Israel is a young country. But what I'm not sure that you are aware of is that we are the country that is most rapidly aging in the Western world in terms of the aging rate. So we will see more and more of those chronic illnesses as we go in the coming 2 years. We're going to see an increase of 40% in the prevalence or in the population percentage of the over 65-year-olds. So you can understand what that will do to the statistics I've shown before. So what's the problem about treating multimorbidity? There are several issues that we need to take into account. It's all the challenges that you know in treating chronic illness, and I will not go into the chronic disease models and the classical theories, but you need to take into account all of those problems with chronic illness and then add some synergies. Disease-disease synergies, drug-drug interactions. Some of these patients take 15, 18 different drugs. This is not unusual for a patient with 5 chronic illnesses. Multiple providers need to start talking to each other, which is a big issue and a big problem. In the United States, for instance, the patients who have 5 chronic diseases see 15 different providers every year, which don't talk to each other usually. So how do you make them try to create a reasonable care plan for this patient? Now, you can probably, those of you who have tried to take antibiotics for a week, how many have succeeded in completing the task of taking a single antibiotic for 1 week? Many of us fail. Now think about the patient who needs to take 18 different drugs in different regimens across the day with morning, evening, forgetfulness, costs, a lot of burdens on the patient, on the families. And just think about, for instance, about diet. Okay, so what can the patient with 5 chronic illnesses eat? Because of the CHF, he can't eat salt. Because of the chronic renal disease, he can't have protein. Because of his diabetes, he can't have sugar. So what is he left with? So if you want to follow the guidelines, you can't basically live. And finally, there's no evidence-based medicine. If you guys think that we are doing evidence-based medicine, you're wrong. In most of the treatments that we give to our patients that we see every day, there's no single manuscript that has shown how to treat a chronic heart failure with 5 chronic other diseases. But that's the patients that we see. There's only about 5% of our patients with just CHF. Most of them have other illnesses. And there's no data, and there's no literature. And the literature is very biased towards very specific subgroups of the population, unrepresentative of this population. So what we actually do today is faith-based medicine. Okay? We have faith in what we read in the general manuscripts that we read and the guidelines that we have, but they have not much to do with the population that we treat. And we need real-life data to know how to treat them well. So this all brings a lot of burden and a lot of challenges to the teams that treat this population. And what we generally do as a health system is to tell our frontline staff, basically everybody sitting in this room, to do more. Because there's fewer resources and because there's a lot more patients to see. So you need to work harder because you don't work hard enough. So we keep on telling them to do more and more and more. But at some point, this cannot continue and this will break. because basically at the end of the road, we are now one of the most efficient health systems in the world. We do much more with much less resources. We have the smallest amount of nurses per capita in any other Western world. The number of beds, I don't need to tell you guys, the number of beds that we have is probably the lowest one in the whole Western world besides Mexico. And the number of physicians is currently okay, but it's going to plummet down in the coming few years, so we'll become, in that aspect as well, a third world country. So this is where we're standing, and we're taking all of those constraints and we're trying to tell our staff that is working very hard to do more and more, because there are more and more chronically ill patients with more complex diseases. That cannot stand. In terms of costs, same approach basically. The cost of the multimorbid patient is several times higher than those of the average patients that we see that are younger and healthier. And you've mentioned before Clalit as an example. Yeah, you shouldn't go to Clalit because, yes, indeed, we see more complex patients. We have an overrepresentation of the elderly population, an overrepresentation of the underprivileged population that is multimorbid. And the meaning of that to all of our costs is considerable. So, where are we now? We are now understanding that we cannot keep on doing the same thing that we've done always and try to deal with this because this will break. And our system is basically broken. When we try to treat chronic illness right now, the way the system is built, it was built for the peasant in the field that fell down and broke his arm. And therefore, you have a system that's built on the patient that have pain or discomfort, going to his general practitioner, asking for care, and then being fixed and sent back. This does not work for chronic illness. So this working silo that we have today, that the hospitals and the community do not speak well enough, that the data between them is not well enough correlated, that is not seamlessly available on both sides, that's a very big issue. We tend to give equal treatment. Equal treatment sounds fair, isn't it? It's good. Everybody gets the same. Well, that's the most unequitable type of care that we can give, because what we should do is give the patients according to their needs and not giving the same kind of treatment and the same access for everyone regardless of their needs, which is, in the best case, this is what happens. We need to change the whole thought from a therapeutic approach to a preventive approach. And I will show a few examples of how we are trying to tackle that. So this paradigm also has to change. We're doing reactive care. If you have pain, you go to your physician. If you don't have pain, stay home. That does not work in an era of chronic illness. You cannot be reactive. Anybody knows this? Probably not in this institution. But generally speaking, we're still in a highly paternalistic working environment in the way we treat our patients. And the patients, the acknowledged patients in the internet era, want to be much more involved. And generally speaking, for chronic illness, that's the only way, if you want to have adherence and persistence, is by having the patient take part in his care. And finally, we're doing things that have no practical utility. And we are giving care that brings no benefit and no value to the patient. And we do it because our ancestors did that and because that's the way we learned when we were taught. So we keep on doing the same practices when much of this is faith-based rather than evidence-based. So if we want to be able to adjust to a multimorbid era, we need to change. And we need to change all of this. So we in Clalit have put forward a long-term plan about 4 years ago to try to change all of this and try to move from the left-hand side to the right-hand side over here and try to do things a little better. And we think that the key to make it happen, to do this very difficult paradigm shift, is to use data. It's all about the data. And if you will do wise use of data, you can change. And if you will not, you cannot adapt your system to fit the current challenges of the current era. So we are fortunate because in Clalit, people have been smart enough decades ago to go forward, put large investments in IT and have electronic medical records and administrative data systems put in place fairly early in the 80s. And these have constantly improved through the 90s and current recent years especially. And another thing that we are very fortunate to have, and I think by now all of the different HMOs in Israel today have, is an EMR system with a single software that's available in all of the endpoints in the community that pours all that data into a central data warehouse. Within this data, what's unique about Clalit is that we have there both inpatient and outpatient data, because Clalit also has a chain of 14 hospitals. So you can have an integrated system approach both to the data and to the care. And that is what we're trying to do. Another good aspect that we have is we already have about 100 chronic disease registries already there for over a decade. So basically what we have, if you sum it all together, is basically decades of full lifespan ID tag geocoded EMR-based data on over 4 million people. And that is an interesting resource if you want to change, transform healthcare. This is a good starting point, but it's just a starting point. And there's a long way between this theoretical benefit or resource and into actual meaningful results, insights, and changes in policy. In order to help this transformation take place, a real change in the mindset of the organization has taken place about 3 years ago when the Clalit Research Institute was established in March 2010. And it was really a change in the organizational mindset. People who know Clalit know that those changes take a lot of time to happen, and happen very gradually. It's a big ship. It moves slowly, but when it moves, there's a lot of power in there. And the mandate of this organization is to take data, turn it into insights, and then take those insights and turn them into policy, into care models. And the beautiful chart that you've shown before of a learning system, this is the same approach that we're trying to take, to go from research into policy, into care models, into actual interventions, do assessment, understand where we are, do a learning system approach, go back to the bench or to the population data, and redesign the system accordingly. And you have 3 examples of how this can be done in real-life outcome research, in data-driven care models design, and in new measures for patient-centered care. And I'll try to give a few examples to each one of those. I'd like to acknowledge Dr. Moshe Chosh and Dr. Becca Feldman sitting here, which are the 2 directors of the key parts of the institute, both on biostatistics and on epidemiology and research. And we are very fortunate to have in this team, in this Clalit Research Institute, a large team by now of really epidemiological statisticians, algorithmic experts, IT experts, clinicians. So this multidisciplinary group is really able to do this very complex process of turning this data into insights. And the examples that I give are all their work. So I don't think we'll have enough time to touch upon too many of these examples that I thought I'd mention today. We'll see how that goes. I'll try to give a few examples of how we're trying to transform care, chronic disease care, to more equitable. One example, perhaps some coordinated care, and we'll see if we'll get to preventive and proactive as we go along. So the first case study that we'll try to touch upon very briefly would be about integrated care and how data can help us give better integrated care across the different silos of care. So the topic I'll talk about today is called readmissions. I think anybody who works in a hospital in the last few years have by now seen this concept, has been talking about it. It has been an issue not only in Israel, but in other places around the world. It's become a priority, and we'll soon understand why. The first thing I'd like to say is that readmission is not a bad thing. The people tend to think of readmissions as a block of malpractice, bad care, anything of that sort, which is, of course, couldn't be further than the truth. In many aspects, readmissions are part of medical care. In a very good chunk of the cases, readmissions are necessary, are important, and are inevitable. But a significant proportion of readmissions can be prevented and is not needed, as in is actually associated with bad outcomes. So if you have high readmission rates, it's a good indicator of unintegrated care. So if you see differences across your system between subsegments, then you can say that there it's a very good indicator and you should use it. Data from around the world, in this case it's data from UK, shows that the rate of readmissions is going up, basically. So we see more and more patients coming back to their hospital within 30 days after they completed their care. We have data that is showing, at least in Clalit, that patients that undergo readmissions are turning sicker. The readmissions are longer. The rate of complications is higher. The rate of mortality is higher. Readmission is bad for you. So as much as you can avoid it, it is something that should be avoided. So if I just told you that we have a very efficient system in Israel, which means that it's starving. Basically, health systems in Israel are starving, and we're trying to do much more with much less. And the key example is that we have one of the shortest length of stay in hospitals anywhere. So it's 4 days on average. 90 people per bed per year. People just, it's a warm bed approach. As soon as the bed is becoming clear, somebody else takes it. So if you'd have to guess where we are standing as compared to the rest of the world in terms of readmission rates before we started our intervention, what would you have guessed? Would our readmission rates be higher, be same, or be lower? Taking into account that our length of stay is very short. Higher. That was our preliminary assumption as well. So what we've done, we tried to compare ourselves to the rest of the world, and it was a really big challenge. And this work, and a lot of work on readmissions is work we've done with Dr. Efrat Shadmi from the Haifa University, a very good collaboration happening there. And we try to compare it with 3 systems that each one defines readmissions differently. We'll talk a lot about definitions today. It's all about definitions. So just a single simple word that's called readmission. So how do you define readmission? 7 days, 30 days. Urgent admissions, all admissions. All ages, 65 plus. Internal medicine or surgical as well. Do you include the emergency units or not? So with just one word, you can understand how the Babylon concept can come into play. So each one of these defined it completely different. We took their definitions, adopted it, and then made a comparison. To cut a long story short, we're doing better to start with. Despite our short length of stay, we have lower rates of readmissions, and that's very interesting, and it's something that shows the strength of an integrated care system when the hospitals and the community can work well together. So this we want to improve. And our Ministry of Health have decided that we will decrease our rates by how much? 10% in the first year and 20% in the next year, which has not been done anywhere across the globe. This is completely detached from reality, but it's a good kind of horizon to look at. So how do we do this? How do we actually reduce readmissions? So we had a very, there was a multi-pronged approach that we've taken. Both at continuity of data, care transition. We put nurses in each one of the hospitals trying to improve the care of the patients at high risk, and to create a contact in which as soon as the patient gets out of the hospital, he will get a call from his community clinic to ask him how he's doing, whether he has his medication, whether he has pain, and what he needs, and whether or not he needs a team to come back to his home or bring him into the clinic in order to take care of him. So I don't care if this reduces readmissions, this is good care. This is the kind of care I'd like to get and I'd like my family to get. So whatever happens to readmission, this is a good thing that should happen. So one of the key concepts that we're working when we do data-driven care in chronic illnesses is we're trying to do targeted care. We're trying to do personalized care. We're trying to have a more smarter approach. But there's a problem with predicting readmissions. It's just really difficult. And you know, when they say in very polite English, a complex endeavor, what they mean is good luck. Will not happen. So basically, again, because of the lack of time, I would have gone and would have in a lot of detail on how we do predictive modeling in the Institute. And we have by now have a good track record of creating quite a few of these predictive modeling approaches to care and care models that are based on predictions. We have taken a large set of data, different types of data, and have been able to create a predictive score that's able to identify at the point of admission what is the likelihood of a patient coming back 30 days when he will be discharged without introducing the data upon his admission into the formula. So, and this was, I think, the first of its kind out there. I hope we'll finally find the time to actually write it up and publish it in the coming few weeks. But this is a model that works very well, and it has higher ROC curves than what we've seen in the literature to date. So this is working. But what we're trying to do is not do nice academia or nice papers. We're trying to change care, to transform care. So how does this go into practice? So this goes into practice in the sense that nowadays, every morning, when every nurse in a Clalit clinic opens her computer, she sees a list of all of the patients that were discharged in the last few days. And those lists is not random. She sees them according to a rank, according to the risk scores that I've just shown. It's already in the data systems. It's already going back to the clinics. It's feeding into the decision process of the nurses. They are calling them according to that. They are using an embedded questionnaire within their system to approach the patient, see if he takes his medication, if he has all the medication, if he knows what to do in time of emergency, and make a decision process whether to send the team over, to bring him over. All of that being done. Add upon that, in all of the Clalit hospitals, every nurse receives every morning in the internal medicine wards this list of the patients that were admitted in the last few days. So she can give a differential treatment to the patients according to their risk. And what this does, just so you understand the power of an integrated care system, once we introduce this into play on the third quarter, we finished the research, basically, and creating the models on the second quarter of 2012. Within 3 months, we had a data system all across the organization. We had a decrease. Look at the decrease in the patients who are not approached by their GP. We have started off with a very good percentage. Only 35% of our patients did not get a contact with their general practice clinic within a week. And now, just 1 year into the intervention, we are reaching below 15%. So this is, in some of our districts, fewer than 10% of the patients do not get approached. So this is, I think, quite a remarkable impact of how data can transform care fairly rapidly. We also see a decline of, by now, almost 5% in readmissions. So this is working very nicely. Time is running quickly. Basically, it's 20...
discussion time, so
yeah, so according to my accounting, I have 7.5 more minutes, but because I started late. But let's do this quick. I'll run quickly. Just to give a few more aspects of equity of care. Probably people here know that just improving quality does not increase equity. It's the stronger subpopulations that absorb your interventions quicker. It's the poor people that are last to improve in their quality improvement. And data, just measuring quality is not enough. And again, just the same theme, everybody around the world tried to reduce equity. Basically, everyone failed miserably. Just very few programs out there that have been able to achieve a real reduction in disparities and increase in equity. We've decided in a public health approach that is very unlike an HMO, basically, to take reducing disparity as a strategic goal. We've done it already in 2008, years before Ministry of Health have started dealing with those issues and putting incentives on them, et cetera, et cetera. And again, because of the lack of time, I will not be able to go and explain to you how we did a very smart use of our quality indicators to create composite scores that are directed at health disparities, identify clinics for intervention, identify 400,000 people that we wanted to take our biggest efforts on, which were the lowest, achieving 10% of our population. We had a whole system and a whole strategy behind this and how this will work. And to cut a very long story, very short, I think this graph helps understand what we've done in just a few years. This graph describes our preventive medicine measures, our classic measures that everybody use most of it by now. Most of the HMOs use the same measures. You can see what happened to them between the 3 socioeconomical status groups in Clalit until 2010. Nowadays, I can tell you there are no disparities in the preventive measures in Clalit by now. When you talk about the most difficult to change measures, the 7 most difficult to change measures that we put in place, we managed to reduce 60% of the differences. And when we stopped the intervention in 2012 to see what happens if we do laissez-faire, whether or not they decrease or not, we see that all of our achievements were maintained, and actually both of the groups actually kept on improving. So we have shown, and this was actually been acknowledged by the OECD in their reviews of the Israeli healthcare system. And maybe I will just mention that when we try to look by now on myocardial infarctions, we see that we are starting to achieve a reduction in the disparities in some of the outcome measures as well, not only of the process measures. So I thought that at this point I would need to leap forward, so I'm leaping forward. This is a traditional work that we've been doing in monitoring non-communicable diseases. Surveys, repeated surveys. This is not the way of the future. The future is on using various types of data, and EMRs, etc., are just the beginning. I'm doing some work with the WHO right now. We're looking at some new ways of monitoring NCDs in Europe, and there's a platform that will be put into play, I think, in the coming years, using additional types of data, social media, mobile data, really innovative stuff that is currently taking place. And so this is some beautiful work that you'll hear more, I think, in the coming few years. There's an ongoing work in progress. But we will have a chance today to hear about all the inadequacies. Okay, there are many problems with using this data. The silent patients that are unrecorded, problem with the harmonization of data, which sometimes make our efforts to unite databases very challenging. Biases in providers, in access, in demographics. If we had the time, we could have talked about it more. But to summarize, the only way to achieve a real transformation in our healthcare system is through data and through judicious use of data. We can use data to get new insights and to change the system, to put in new models, to monitor trends, to identify priorities, to do risk stratification, to target care to the patients according to their needs. All of these sounds like a futuristic approach, but it's not. These are things we do today in Clalit on an everyday basis, by now on the desktops of every nurse and every physician, both in the hospital and the community. As the years will go by in the coming years, we'll do more and more of these, and some of the work that we are trying to initiate in these months today, also in IBD, might be another very important track in that overall direction. So there are a lot of requisites, there are a lot of things still to be achieved, but to finalize, I will just say that it's not enough to do your best. You should actually know what to do, and then you need to do your best. Thank you very much. And type of questions.
Fascinating talk. So going back to IBD, from what I understand is organizations that look at preventive medicine and schedule. I mean, it's very easy to take IBD patients and do the same thing, like pop-up windows. Did you see the eye doctor in the last 3 years? Did you do levels of Imuran? Did you do CRP before you send someone to referral to, I don't know, to endoscopies or et cetera, et cetera? From my understanding is that the organizations are not very willing to go that path, because this is money that goes out now from their budget to questionable saving in the future. And in the end of the day, it's all a balance of money. And this is understandable. So how much is really Clalit or the HMOs are really receptive to the ideas of doing better medicine, of what we think should be a better medicine?
Okay, so you touched upon two really important points. Better medicine, we think, which in some points those two are not necessarily go hand in hand in the what the organization views. And again, we go back to the question of when do you have enough data to show that something that you do is actually useful. It's not necessarily every professional society sees their practices as the most important things that need to happen, and has sometimes a tendency to push forward on procedures and intensive approaches that in public health approaches sometimes not necessarily have been proven to be with added benefit in overall outcomes, overall survival, overall care. You have mentioned in the beginning of your talks, one of you guys mentioned that we should start measuring what the patient benefits from all of everything that we do, which in too many aspects we don't. We try to see surgery as one of the outcomes, but how about some patient-reported outcomes and what they actually benefit? We look at our system as a very complex machine that in one side you put money and in the other side you get health. We don't try to put in money to get money. This is not a cost-saving kind of an approach. If we can prove that any approach is something that adds health and adds benefit, it is something that would be happily taken by any of the organizations that I'm involved in. But there's a question of asking whether or not the guidelines are indeed important. Every piece of thing in the guideline has the evidence for the outcome and the benefit and the end game benefit, not some kind of ameliorating an intermediary data measure that you have, whether or not it adds value to the patient. And if it does, I'm sure it will be inserted. In terms of the measurements, Clalit is now moving very deeply into specialty care, quality measures, and everything that can be shown to be really associated with benefit to the patient can actually become checklists, guidelines, automated alerts, and all of that. We are certainly can prescribe to that if we know that it adds really benefit. Iris. I fully agree, and I want to say more. I think that in the past, the identification of new drugs and new treatment modalities were based on serendipity, and on the likelihood of someone just bumping into the right drug. This is changing rapidly, and in silica and these types of approaches to identify populations that can benefit more from the treatments are at higher risk for developing either the disease or its complications, and all of the other aspects that were mentioned are really the future way to go. I do agree that it can be done in IBD as being a very sole disease usually that you can really focus on, and in the sole attention of both the patient and his family in many aspects. I do agree. I think we are just in the beginning of a very interesting way forward. We can identify new modalities, new ways of identifying the patients, and new ways of treating them. So I do agree there's a lot of potential there. Eric.
So just as a question and a word of caution about the quality indicators that you're using and that you may develop later, especially when it comes to IBD. I think the concern that we've started having, at least in North America, in the pediatric realm, is that the quality indicators for asthma, the quality indicators for IBD, the quality indicators that have been published that people are putting into quality improvement programs are based primarily on RAND methods, so really expert opinion and some evaluation of what's available in the literature, and don't necessarily correlate with the outcomes of the patient later on, whether it's patient-reported outcomes or clinical outcomes. And I think in IBD we're starting to see that with Improved Care Now, which is an extremely expensive method of tracking quality indicators and tracking what people are doing and feeding back to people what they're not doing well. So you already have that, so it would be less expensive for you through the electronic health record. But and their most recent publication has demonstrated a 10% improvement in outcomes, but only in patients with pretty much mild disease to begin with. So I'm sort of just, it's a roundabout way of saying be cautious, that I think I agree with what you said, that we really, really, really need to measure adherence, but also measure outcomes, and find out which are the best quality indicators that correlate with outcomes, and not jump to things like pay for performance before we have validated the quality indicators to begin with.
I could not agree more. I alluded to that, but maybe I didn't say it clearly enough, that there are issues with evidence and with value in some of the current guidelines, and we will not turn any of those guidelines into any quality measures or automated decision support for any piece of information that we're not absolutely sure that adds value to the patient on the overall outcomes, and not in any surrogate measure or any expert opinion. So I think that was now made very clear. Thank you so much. And I have to apologize for leaving early today. Other obligations, as I've noted. Thank you.
So thank you very much to Dan and the organizing for inviting me, and it's very impressive to hear Eric's talk and Dan's initiative now to really start collaboration on epidemiology in Israel is, I think, a great and excellent idea, and that's the reason that we're all here. But some studies were done up to now nonetheless, and I've tried to sort of summarize them. And historically looking, if you look at the 70s to the 90s, you can see that in Israel, it was mostly different groups working in different districts of areas. So you had the group of Gilat and Rosen working in the area of Tel Aviv, and then the group by Jerry Fraser and Otis here looking at the south of Israel, Beersheba, and then the north of Israel, Fireman and Niv. So I've just written them here just so you can see that collaboration was not really perfect in those times either. But I think one of the studies, actually a set of studies that I've shown here, referenced here at the bottom, led by Niv, were in kibbutz populations. So we know that there, at that time, the last of these was published in 2009, 269 kibbutz settlements in Israel with a total of 117,000 people, accounting for 2.4% of the Jewish Israeli population. So we can see this is a very highly selected group. Nonetheless, their kibbutzim are fairly dispersed throughout Israel. So geographically speaking, at least it was something that was throughout the country. And Niv's group did 3 surveys in 1987, 97, and 2007. And I've just summarized the last one with first talking about ulcerative colitis. There were 255 confirmed cases of ulcerative colitis with a female-to-male ratio of 1.2 to 1, so actually a bit more for females. And he could show that the prevalence rate rose from 121 for 100,000 to 216. That means doubling throughout that time, while the mean annual incidence increased from 4.7 to 6.7. So again, the prevalence rate was higher in women. It was more in European descent, more than or American-born than Asian and African, and even more so than in Israeli-born individuals. And we can see graphically the changes in prevalence, and we can see graphically the change in the according to the different origins here. And we can see that there is, maybe you can also see that there is some catch-up of those born in Asia and Africa regarding the higher rates beginning in the European descent or Ashkenazi Jews. And there was no significant difference between the surveys in the number of patients with medical history of appendectomy, tonsillectomy, measles immunization, or cholecystectomy. So we talked before, looking under the lamp, those were the things that specifically were more talked about at that time, so they were asked in this survey. And there are more active smokers in 1997 than in 2007. So in a different publication, they looked at the same population for Crohn's disease, and there were 133 confirmed cases of Crohn's disease, and the prevalence rate here rose from 26 to 113 per 100,000, and the annual incidence rate rose from 4.8 to 5.2. So here we can see graphically that although in the 80s ulcerative colitis was much more prevalent, there seemed to be a much higher slope for Crohn's disease throughout those years. And we can see when we stratify to the different origins the same sort of maybe catch-up that we could see in the previous study as well. So if I just put them graphically or in the same slide, we see that the prevalence of UC was higher at the 80s, but increased 2-time-fold to 2007. But the prevalence of Crohn's disease actually increased 5 times more in the same population throughout those 20 years. So our study in the IDF, which we published already in 2004, we could again look at the prevalence amongst 17-year-olds or pediatric prevalence. And what we could see that the prevalence of Crohn's disease among pediatric patients rose very steeply compared to ulcerative colitis, which stayed mostly stable. And unfortunately, after 1995, the codes that were used administratively in the IDF were unified for Crohn's disease and ulcerative colitis, so we could just get the total rates for IBD. But if we sort of project these curves, we can imagine maybe that the continuation of rise in the slopes is mostly due to Crohn's disease, but this is just conjecture, and we could not prove that. Now, since Zohar Levy has just published in the IBD journal a continuation of the same idea of study, I'd like to maybe more concentrate on the data that he's published. So they've checked 950,000 Jewish Israeli adolescents, of which 58% were men. And in the IDF, all conscripts go a general health examination at the mean age of 17. And it actually does include almost all the Jewish population in Israel, except for Orthodox women, which is a minority, which do not pass through this health examination at the conscription sites throughout Israel. So in this study, all these conscripts to the IDF were included between 1998 and 2010. And a total of 2,021 patients with IBD were identified, which is 0.21% in 13 annual cohorts. And what they could show was that the prevalence of IBD, again, the 17-year-old prevalence or pediatric prevalence rose from 149 to 301, almost doubled from the first to the last cohort. And this is graphically, we can see the trend. Now, the problem here, as was in the previous study that I showed, that it was very difficult, is impossible to dissect out Crohn's disease from ulcerative colitis, so you get these graphs of total IBD. And through multivariate logistic regression, they could show that being male was statistically, but I don't know if clinically, more significant for the risk of IBD. Again, being from the West, European or North American, carried a higher risk. And they introduced this socioeconomic status, which I'll talk about a bit later, how they define that. And they could show that being from a high socioeconomic state was higher risk for developing IBD as well. And also something about the number of children in households, which I'll talk about later in a different study that we did as well. So Eric is going to talk in the next session about the pitfalls of using large administrative databases. So for this study, I would just like to talk a bit more about how the different definitions were done. So using the IDF administrative database, IBD is confirmed by a medical recruitment board composed of 3 physicians who are not gastroenterologists, but we know that each of these constructs is referred by a specialist in gastroenterology. And what they did was they validated the diagnosis for all IBD cases in 1 year, and that was in 2010. And they did this by actively reviewing the files by 2 independent gastroenterologists. So of all the cases, 55% were Crohn's disease, 35% ulcerative colitis, and 10% IBD undetermined. And the primary inter-observer agreement was substantial. And in only 1 of 220 files examined, the diagnosis of IBD was not confirmed, so high specificity of 99.5%. How was socioeconomic status, for instance, defined? So it was ascertained from the Israeli Central Bureau of Statistics according to postal code, and there was a scale from 1 to 9. And the data was ecological, but included multiple variables such as income, size of housing, or density of living in the household, number of children in the family, number of cars, years of schooling, and data about taxes as described in the CBA site. So this is actually, we need to go very well into these different definitions to understand exactly what we're talking about. And what about origin? As Eric said before, the importance in Canada is of the mother. And that is always true for Judaism, I guess. But in this case, the IDF, the country of origin, was defined as the country of origin of the father, or if the father was born in Israel, of the parental grandfather. So nothing much to do with the mothers. And that, I guess, is a problem as well, because we have so many children who are of mixed origin. So the next study that I want to talk about is the hygiene hypothesis, and Eric talked about different environmental factors a lot. So our contribution to this, which we published in 2008, and was again done through the IDF. And already in 2008, we were talking about some patterns of exposure to microorganisms in childhood that may be associated with the risk and phenotype of CD. And now, of course, everyone is talking about the microbiota much more than it was then. And the hygiene hypothesis was first proposed in the late 1980s to explain the rise in allergic conditions such as asthma, atopic dermatitis. So we thought that it would be a good idea to check that as well for IBD. So we did a cross-sectional population-based study, and information on the number of siblings, birth order, and living in an urban versus rural environment was obtained for almost 400,000 Jewish conscripts, adolescents at the age of 17 from 1998 to 2004. And again, our definition of rural was actually very interesting. We were very interested in the microbiota, or living close in proximity to farm animals. So we actually had a data set from the Ministry of Agriculture that listed every one of the settlements in Israel according to the proximity from farm animals. So that was our definition for rural versus urban. And in total, 768 cases of IBD were found, and 54% of them being Ashkenazi. And so in our multivariant analysis for the risk of developing IBD, we could find male gender, again, not surprisingly, Ashkenazi, and statistically speaking, at least, being born in a rural environment imposed a risk of 1.4 odds ratio, which was statistical but not very high. And what was interesting was the number of siblings in family. And in our population-based study, it was rather interesting because compared to others, there were many families with 5 or more siblings, so that we can really take a good look into that. And we saw that actually being with 5 or more siblings was actually protective, or being less than 5 siblings was actually a risk factor for developing IBD. And again, the birth order was also important in that sense, that being the 5th or higher in the rank as opposed to being the 1st imposed a risk for IBD as well. And we could show that this was, when you stratify the different origins, the number of siblings remained as much for the different origins a risk factor for, or a low number of siblings, or being a single child was a risk factor for developing IBD. So the main findings of this study was that an independent increase in risk for IBD with a decrease in the number of siblings, the lower rank of birth order conferred a decreased risk for IBD. And we thought that all of this was actually surrogate markers for domestic crowding. Not in itself, the number of children is important, but domestic crowding. And it was a significant increased risk when growing up in an urban compared to a rural environment. And just to show that there was a correlation, we could not really measure directly domestic crowding or how many people were living in a household, but again, we turned into the Central Bureau of Statistics in Israel, and for different years we could show that according to the number of persons in a household, the average number of room per person was changing. So for instance, if you were in a family of 4 people, that meant 2 siblings usually, then the average number of room per person was around from 0.86 to 0.99. But if there are 2 more siblings, the number of rooms per person was significantly smaller. So there was correlation between the number of siblings and the crowding in the household. But of course, we didn't measure that directly. We were just projected this from these data from the Central Bureau of Statistics. So my presentation is rather short. I was asked to talk for 20 minutes. I could summarize. I'd like to summarize. In the 80s, there was a higher prevalence of UC, but this is sort of stabilized, and this is according to just the studies on the kibbutzim. We don't really have a registry as much as Eric has showed before, but so we can just maybe tease out these from not too many data that we have. From the 90s, we see an increase in Crohn's disease, especially in the pediatric population, and actually in the 17-year-old, the prevalence has increased 5 times fold throughout from the late 90s to the early 2000s, and from what Zohar also examined in the late decade of 2010. There's also a catch-up in the incidence of Sephardic Jews as well as mixed origin, Israeli-born. The environmental factors that we could find in the studies in Israel were socioeconomic status, which are mainly ecological studies, domestic crowding, as I've showed, which is protective, and maybe growing up in a rural environment, which has turned out to be the same in some of the studies that Eric has shown. Thank you.
Okay, and we'll ask Dr. Zohar Levi to step up and lead the discussion, the questions, etc.
Okay. Well, we've seen this morning that probably by good treatment, we can influence the outcome and have better outcome for our patients. We also seen that there's a dramatic increase in the incidence of IBD
In Israel, this is probably true according to several observations. And we also seen that the issue of prediction, we can probably predict those that will have poor outcome, or we also can see those that already have poor outcome. All this we can see. But my question is, what are we doing with this information in Israel? And what are the HMOs doing with this information? And I will answer, before the discussion, what I really know. What I really know from what I'm seeing, that patients, some of them are going to several patients in the HMOs and those gastroenterologists. Some of them are IBD specialized, some are not IBD specialized. Some are going in circles between the HMOs. Some are going in circles between the privates and the hospital and the outpatient gastroenterologist they have. And the real obstacle, according to what I see, is that the gastroenterologists are not willing to share these patients of them, from one point, and the HMO, whichever HMO on the other side, are not willing to do anything with this information they can catch up by their computers. So my question is, do we have, or can we, put some statements or guidelines, say, patients, please say to the HMOs, please, those that are on immunosuppressive treatment for that and that years, those that have already complicated disease according to surgery, because you know who underwent surgery already, or those that, you know, other predictors that can be defined, high CRP or whatever, starting at an early age. Can we have a statement to the HMOs, guys, this is not a political issue, this is really a nice try to affect and influence quality of treatment? Can we say, we want these and these patients, please pop up these patients and try to follow them. Although they are treated in centers, one or other, or private practice, we can track these traces, we can track them. But can we say to the HMO, please, we want these patients, let them come up and let's see what you are doing with your IBD patients. Okay, this is for the starter. Who wants to comment?
I think the first stage is what you were doing in the last year. What we're trying to do is really to identify the patients.
What I'm trying to be provocative. It's not a big issue to identify these patients. We already did this. Becca is here. We already did this. We know who are the patients. We know who went surgery. We know who is on immunosuppressive. We know who are these patients. But knowing is not enough. And I say, should we act? And should we say, these patients, we want to trace them as a high-risk patients for poor outcome or already poor outcomers? And this is the issue, because here you have to, you have to have a position. Say, okay, these patients, maybe you should focus on these patients. This is because identifying patients is no problem, but you cannot affect, you can have papers from this, but you cannot affect outcome a real outcome just from looking at the computers. Yes.
I disagree with your statement that identifying patients is not a problem. I think it's a big problem. I think that knowing whether the patient got azathioprine or underwent an operation is just one few aspects that are very, very, very important that could make an influence. And that I think that actually what was presented here by Eric, that combining two approaches, the big data approach and the laboratory or bedside approach, is something that will actually yield the highest result, the best result. And I think that in principle, we are actually, when I say we, all of us,
of course.
I think we're pretty much in that direction by having a project led by Dan, and which you're a part, and all the HMOs are actually part of, trying to identify the administrative database, and the other project that essentially all of us are leading. Jerry is taking the lead on building a biobank for having this translational research. I think that the answer is a few years ahead, but I think that is the direction.
Yes, Iris?
I would disagree with the other part because I think that identifying is one problem, and once you have the patients, you want it to be competent. So outcome measurement is not the only thing. So it was very impressive to see how Ron was showing it. This is definitely one goal of therapy. But if we want to understand, shown like immunopathogenesis, and so we need to look at the patients, and we need to compare those patients that you identified with everyone else in Israel, and to compare rural versus urban, getting antibiotics or not, and then you can try and take it to more mechanistic studies and try and have the best outcome that you can have, which is one day prevention or cure, right? God forbid. So this is actually one thing, one important thing that we want to do, in addition to prevent readmission or to make sure that the patient doesn't get 6 months steroids in a year.
Okay, I agree. Yes. Amit.
Database that we have now, a beta version for IBD, an entry of very detailed IBD demographic cases, pre-medication, etc., that is going to be available to all and every IBD treating physician in Israel. This is exactly the effort that has been done for the biobanking. And one part of the database is exactly what you said. The other will be an effort to biobanking.
Yes, Eran.
So I agree very much with the model that Eric showed, and I was very happy to hear Ran Balitz as well, because it sort of gives us as people who are dealing with gastroenterology and IBD sort of this framework of how large HMOs are doing. So on the one hand, it is from the bench to the bedside and from large information or huge information databases that you can acquire. So of course you're right. I think it's very important in the beginning to get the data. It's very important to speak the same language and to cooperate between organizations in order to first of all get this observational data. The higher quality you have from the database, and we'll talk I guess later about the administrative database, that you can always look under the lamp of what has already been defined. So for instance, when I was in the IDF and we looked at different diseases in a sort of mechanistic way that soldiers have to occupational manner, then we unified Crohn's disease and ulcerative colitis, because the IDF wasn't important for them. It was giving them, leave of absence from the IDF. So I think we have to first of all concentrate on getting these large databases speaking in the same language in order to get the observational data as high quality as we can. And then only from then we can take these hypotheses further. Because I think that one of the important things is observational studies, get hypotheses that we can sort of later on generate other studies which are not just observational. So it's sort of a loop that's going around, but you cannot, certainly you cannot not go over the stage of setting the stage of having the data set together.
Okay, I agree. I also want to comment to Eric. In Israel, the HMOs have accurate data about drug takings. So because there's actually no OTC, the OTC are expensive, and the finance for the drugs is 100% or close to 100% for most of the drugs. So every tablet that the patient takes is registered and can be traced, and this is a major strength of the data of the HMO, of all HMOs.
Just a quick comment that my talk was really focused around doing, bench to bedside health system population level, trying to find the cause. That being said, most of my research is in health service research where we only use the data available to describe what's happening in the healthcare system in order to identify inefficiencies or unwarranted variation in care, changes in prognosis, so where we can tell patients what their prognosis is. So there is value, there's strong value to using just administrative data to conduct research. It's not saying that you have to have the clinical or the microbiome or the genetic data linked in. I think the holy grail, the thing that we're all striving for is linked clinical and biologic information with the admin data. But I think, you can't underestimate the value of describing the health system and how patients are being treated in improving the quality of outcomes. I think it's sort of both aspects.
Yes, Jerry?
So even the most simple of data has major implications. I mean, we saw in our paper a doubling in 12 years of prevalence of IBD in the under 18 population. And this is going to have big implications for our healthcare system, costs in IBD, and for the HMO. So simple data can have quite a big impact on what we're going to see and what we're going to have to do in the future.
Okay, so I hope that we'll all agree that there is extreme importance to have a large data to look at, and thank you.
If we are doing a gross division of the population in Israel, we can divide them into Jews and Israeli Arabs. And the Jews are further divided into Ashkenazi, Sephardi in Yemen, and Ethiopian Jews. In my lecture, I will focus on two minorities in Israel, the Ethiopian Jews and the Israeli Arabs. In Western countries, the prevalence of IBD is quite high, and it can reach 229 per 100,000 for UC, and approximately 200 for Crohn's disease. And in Israel, it's quite prevalent, and it is, as you can see, over 200 per 100,000 for UC and 100 for Crohn's disease patients. What about the Israeli Arab population? We know that there are 1.5 million Arab Israeli citizens in Israel, which are approximately 20% of the Israeli population. Most of them, 83% of them, are Muslims, and there is scarce data regarding the prevalence of IBD in this population. If we are looking at the Arabic population centers, most of them are located in the Galilee, 60% of them, another 20% in the Triangle area, and other 10% in the eastern Jerusalem and mixed cities, and 10% in the northern of the Negev, especially the Bedouin Arabs. The first study I want to present was done by Odes and its group from Soroka, and they aim to find what is the prevalence of IBD in the Bedouin Arabs in the southern part of Israel. The Bedouin Arabs are mostly rural, over 80% of them, but most of them live in a short distance from town. And this study was prospective and was held between the years 1981 and 1990. And during those years, they found only 8 patients with IBD. Most of them, 6 out of 8, were with UC, and only 2 Crohn's disease patients, and 6 out of 8 were females. What about the prevalence? We can see that for all ages group, the prevalence was quite low. It was 982 per 100,000, and slightly more prevalent in women. And for Crohn's disease, it was estimated to be 3.2 per 100,000, and slightly again more prevalent among women. Just to compare, in Jewish population in those years, the prevalence was 89 per 100,000 for UC and 31 for Crohn's disease patients. So they found really low prevalence among this population. This low prevalence was similar to those reported in Kuwait, and they conclude that the Bedouin Arabs have adopted Western living and eating habits to a limited extent in the past 50 years, and this possibly accounts for the recent occurrence, yet very uncommon, of IBD in this population. The other study was done in collaboration of some hospitals in the north and also in collaboration with Wolfson and Hadassah. And the aim of this study was to find out what is the prevalence of genetic mutation in NOD2 CARD15 in the Arabic population in comparison to the Jewish population. So they collected 66 Arab Crohn's disease patients and compared them to 122 Arab controls, and also took Jewish Crohn's disease patients and Jewish controls. And as you can see, for all mutations, it was quite low. It was estimated to be only 7.6% of the patients, and if we compare them to the Jewish Crohn's disease patient, it was much higher, 93 or 38% of them. Yet, when they found out what was the phenotype of the disease in the Israeli Arab population and the Jewish Crohn's disease population, you can see there was no difference in terms of gender, smoking, extent of disease, type of disease. The only difference was in the age of diagnosis, which was slightly older in the Arab Crohn's disease patient. They conclude that maybe we see a very similar phenotype, a very different prevalence of genetic mutations. There are environmental factors that contribute to the development of IBD in the Arab population. The other study, which was published recently in the JCC, was conducted by the Zvidi and its group from Bellinson, and they aimed to find out what is the prevalence of IBD in an Israeli Arab population. They contacted all family doctors from all Arab towns and villages across the town, and in total they got data from 23 out of 71 Arab municipalities. They reflect 200,000 of the Arabic population. So they collected 108 Israeli Arab patients with IBD, of them more Crohn's disease patients, 64 and 44 ulcerative colitis. We can see that the prevalence was 22 for ulcerative colitis and 32 for Crohn's disease patients. Again, no prevalence of IBD in this cohort. And regarding smoking, you can see it was very uncommon in the Crohn's disease patients, only 1.5% of the patients, and 18% of the patients with UC were active smokers. If we are looking at their clinical state, it is very impressive to see that most of the patients, 75% of them, of both Crohn's disease and UC patients, were in remission or in mild disease. If we are looking what their therapeutic regimen was, we can see that most of the patients got 5 ASA, and only minority of them, 6.8 of the UC and 18% of Crohn's disease patients got infliximab. This may reflect also maybe the milder phenotype of the disease in this population. And now I want to present our experience, which is unpublished yet. Our fellow, Dr. Mohamed Mahmoud, works in a large clinic in Atzeret, which is the largest Arabic town in Israel, and its population estimated to be around 66,000 citizens. And it also has high concentrations of Arabic population, which are referred to this clinic. So during the 3 last years, he collected 65 IBD patients. All of them were Crohn's disease patients. There were none with UC. You can see that most of them were Muslims, and the mean age of diagnosis was 36. You can see there is a large standard deviation because the youngest person was 10 years old and the older was above 70. Most of the patients were male, and we can see that most of the patients, 71%, were married. Regarding their habits, you can see the only minority of them were alcohol consumers, and 20% of them were active smokers. Again, around 50% of them had mild disease, 23% need surgery, and approximately 90% of them, the disease was limited to the terminal ileum. You can see that over a third of them had extraintestinal manifestations, and over 50% of them had positive ASCA. Regarding the type of medical therapy, again, you can see that most of them got 5-ASA, above 80% of them, and only minority of them got anti-TNF. It was below 5% of the patients. Again, it can reflect maybe the milder presentation of their disease. So in conclusions, relatively, the Arabic population may have mild phenotype of disease, mostly TI involvement, and maybe older age at presentation. The other minority which I will focus on is the Ethiopian Jews. We know that between 1985 and 1991, there was a substantial immigration of Ethiopian Jews to Israel. And also we know that IBD is extremely rare in rural sub-Saharan Africa. Actually, there are only few case reports of IBD from Ethiopia. Until now, there is no data about IBD characteristics in this population in Israel. Some data regarding the Ethiopian population, it estimated to be over 100,000. Most of them are immigrants, and the large immigration was between the years of 84 and 1901 in the two Mivtza Moshe and Mivtza Shlomo. Most of the citizens are urban, and most of the Ethiopian citizens are located in the central and southern part of Israel. So we aimed in our study to characterize what is the phenotype of Ethiopian IBD patients in Israel. So we contacted hospitals all over the country and asked for clinical and demographic data of their IBD patients. At last, we got data from 7 hospitals in Israel, from our institution, Hadassah, Kaplan, which gave us a high percentage of patients. Maybe it is related to the fact that there is in Rehovot a large population of Ethiopian Jews, from Sheba, Rabin, from Rambam from the north, and from Soroka from the south. All Ethiopian patients had a diagnosis of IBD, and we collected demographics, clinical characteristics, and clinical course of their disease. So at all, we had 32 patients which were included. The age of diagnosis was 21, and 75% of them were born in Ethiopia. What is very interesting to see that the mean interval from immigration to disease onset was 12.5 years, plus minus 4 years. We saw that no patient developed IBD before 8 years in Israel, okay? So maybe it is a de novo disease that happened to them when they moved to Israel. Regarding most of the patients were male, and most of the patients were single. It may be related to the younger age of the population included. Again, you can see 94% of them had Crohn's disease. Only 2 patients were with UC, and nobody of them had family history of IBD. 63% of them had above 3 years disease, and 72% of them were diagnosed above 17 years old. Regarding their profile, it's very interesting to see that 27% of them had upper GI involvement. Only one patient had extraintestinal manifestation, and 50% of them had recurrent admission. Another quarter underwent surgery. Regarding their disease status, you can see that 60% of them were in active disease during the study. What about the phenotype of the disease? 70% of them had inflammatory phenotype, 86% of them had no strictures, and 24% of them had fistulas. The second step we have done, we took from our cohort 33 Ashkenazi Crohn's disease IBD patients, and we compared them to the cohort of the Ethiopian Jews. And the two cohorts were very similar in terms of extent of disease, of number of admissions, type of medical therapy, but there were some difference which were statistically significant. You can see that regarding family history, there was no Ethiopian Jew with a family history, and 42% of the Ashkenazi Jews which had positive family history, and this difference was significant. And also the age was younger in the Ethiopian Jews. Another difference which was very significant were the upper GI involvement, which was very prevalent in the Ethiopian Jews, and also the prevalence of extraintestinal manifestations, again, more prevalent in the Ashkenazi Jews. So, if we summarize the data, all the patients developed IBD at 8 to 16 years following immigration. Most of the patients have inflammatory type of disease, mainly ileal involvement, and upper GI involvement is more prevalent in the Ethiopian Jews cohort. Scarce data regarding prevalence and phenotype of IBD among Israeli Arabs. No data in the literature about disease characteristics in Ethiopian Jews. There is low prevalence of IBD in the Israeli Arab population, but the incidence of Crohn's disease is increasing over year. They maybe have mild presentation of the disease, and in Ethiopian Jews, there is increasing prevalence over the years, much more Crohn's disease patients, more upper GI involvement, and no family history of IBD. So in conclusion, gastroenterologists should be aware of the unique phenotype of IBD in different ethnic groups, and this may also help to identify environmental and behavioral factors contributing to the development of IBD. Thank you.
Thank you again for asking me to speak twice. It occurred to me recently that maybe this was too negative a title. Perils and pitfalls implies, what can go wrong when you use when you use health administrative data. But I think the message here is that we're learning, right? We're learning what issues there are with these data and what methods we can use to overcome these data. So it's not just negative, it's also positive that we're hoping to improve the methods. The objectives of this talk is to define health administrative data, what it is, and identify some advantages and disadvantages of using the data for research. Identify important methodologic concerns in the identification of patients with rare chronic diseases, such as IBD, considered relatively rare, especially pediatric IBD when you consider other diseases like cancer. Explain advances in our understanding of identification algorithms, the way we identify patients, and I'll define this better in a little bit. But, more positively, it's really 5 lessons that I've learned while playing with my data. And I say my data because it's obviously shared data amongst the whole province, and many researchers are allowed to access it. But when you're doing your PhD at my research institution, they don't assign you a data analyst to actually work with the data. You sit there for 4 years and work with the data yourself in SAS. You develop an unhealthy attachment to these data. So I now think of them as my data. So sort of introduced the idea of health services research, which is the primary type of research that we use these data to conduct. It was developed in the 1960s at the National Institutes of Health in the United States with the understanding that clinical trials were really not a real-world scenario. Clinical trials are a very sterile environment where very specific patients are selected to partake, and they don't necessarily represent the general practice that's going on out there in the real medical world. Whereas basic and clinical research asks the questions, what should we be doing and why? Health services research asks the questions, what are we truly doing? What's really going on? And how does it match up with basic and clinical research? So how do we conduct health services research? It's really conducted best with population level data because you want to get an idea of what the variation is across different levels of care across an entire jurisdiction, entire population. The problem with conducting population-based research with clinically collected data is that it's expensive to collect when you're talking about a prospective or even a retrospective cohort study, very resource intensive to find every patient and to try to get the information in a database, and subject to bias. Realistically, especially in a large country like Canada, you can't necessarily get out into very remote areas and get every patient. So even if you have unlimited funds, it's very difficult to collect every single patient in a given jurisdiction. So that's when we start to look at routinely collected health data to conduct this sort of research, including health admin data. So routinely collected health data is defined as data that's collected without a research question in mind ahead of time. So it's collected for whatever reason, and then you ask the research question after the database already exists. Health administrative databases are an example of routine collected health data, where health administrative databases are really collected in order for the healthcare system to be tracked and budgeted by the providers of care. There are other types of routinely collected health data, such as medical record databases, so electronic health records, doing research in that field, and disease registries, including cancer registries, where they may be collected with the research idea in mind, with the research purpose in mind. They're not collected with the research idea in mind or the a priori hypothesis. So the advantage of using health administrative data for research, we've talked a little bit about already today. I mean, the main advantage is that usually they collect large and very diverse population. In Canada, it's a province, so all patients within a jurisdiction are contained in the health administrative data. It's longitudinal data, so data is being collected for the purposes of planning of the healthcare system, and so you can follow patients longitudinally as long as they remain in that database. In Canada, typically, there's a very low dropout rate, so patients don't tend to move from province to province. A very low percentage of patients move frequently, so you can really follow them often from birth until death. That may be different here. The data is being collected anyway. It's being collected for the purposes of planning the healthcare system, so it's relatively readily available and it's relatively cheap to access compared to clinical cohorts. The disadvantages, though, are also fairly apparent. That firstly, it's collected for administrative purposes and not research, so the research questions you ask have to be able to be answered within the confines of the data that's being collected. It's subject to garbage in, garbage out phenomenon. So in Canada, much of the administrative data is physician billing data, where you attach a diagnosis to the physician bill where they get paid. So the purpose is really not research, and physicians are notoriously inaccurate in the diagnoses that they attach. Their real purpose is to get paid, and that's why they bill. So it really does require validation. You need to make sure that the answers that you're getting reflect the data and that the data is accurate for the purposes of your research. I'll speak to you a little bit about ICIS, the Institute for Clinical Evaluative Sciences, which is my research organization. It was established in 1992 by the Ontario government as an independent and not-for-profit organization with the goal of conducting research that contributes to the effectiveness, the quality, the equity, and the efficiency of healthcare and health services in Ontario. So while the infrastructure is funded by the provincial government, we are independent. We don't answer to them, so any research study that we produce can't be stopped by the provincial government, even if it looks bad publicly. The only caveat we have is that the provincial government has to have 30 days before publication in order to mount a response, to develop a response if a study doesn't look good. Additionally, researchers from ICIS are sort of at the beck and call of the province, so that if the province wants a research study conducted for the purposes of planning the healthcare system, we pretty much have to drop everything and do the study within a very short period of time for the province. That's sort of the give and take that we have with the province in order to access the data for academic and research purposes. So we have a lot of health administrative databases available in the province. Physician billing information is available from 91 onward. Medications, I said, are not reliable, but the reality is that it is available very reliably for patients over 65. So the province does pay for all medications in patients over 65, as well as patients on Ontario Works, which is the welfare system in Ontario. However, otherwise, obviously that's a very biased sample, and otherwise the data is not available reliably for other groups. We have hospital admission databases, such as the discharge abstract database and the mom-baby database we spoke about earlier. We have the registered persons database to track everybody living in the province of Ontario and where they live. We have census information. We have the immigration database, which we spoke about earlier, and we have death information as well as cause of death and autopsy results and things like that. So using these databases, there have been a number of surveillance programs that have been put together using all the different databases. And these are examples of validated surveillance programs that have happened. The most widely used and widely known is Cancer Care Ontario for cancer. And that does actually link some clinical information, mostly pathology reports, staging and grading of cancers from 1961 onward, can be linked to the health administrative data in the province. We also have the Ontario Diabetes Cohort, the Ontario Myocardial Infarction Database, the registered Canadian Stroke Network, the Ontario Asthma Surveillance Information System, and most recently we have the Ontario Crohn's and Colitis Cohort, which I'll speak to you about the validation, and we spoke about some of the results. We also have the Ottawa Hospital Data Warehouse, which I'll speak a little bit about in a second in terms of the validation. And Born Ontario is a new thing for pediatrics, which is great for us, which tracks all pregnancy, including lab results and clinical course, and births and ICU admissions in hospital, and will be following pediatric patients at their well child visits through the first 2 years, hopefully. And that's all housed in Ottawa at CHEOB and will be linked and is being linked to ISIS data, the administrative data. So a nice, rich pediatric resource. So we've conducted at ISIS very high impact research that has, I think, impacted the healthcare system in Ontario, which is really the goal. So this is an example of the diabetes epidemic, the type 2 diabetes epidemic occurring in North America. This is data from Ontario. You can see a very fast rise in the prevalence of type 2 diabetes amongst adults in Ontario, but also a widening of the gap between the low income and the high income in terms of the risk of diabetes, with more poor patients having a greater risk of developing type 2 diabetes. Not only that, we were able to describe what the risks were for complications from type 2 diabetes in the long term. And although, we mentioned income, that you would think income would be a big risk, it certainly isn't the top risk for complications. Region, rural versus urban. But the number one risk was really not having a visit to a physician in the year prior to their complication, stating that access to care is by far the largest risk for a complication for diabetes. So this was one of the factors that implemented regional diabetes centers across Ontario. The government implemented these, where you don't necessarily only get followed by your primary care physician, of which 30% of Ontarians don't have a primary care physician. There are regional centers that you go to for your diabetes care, and they're much more involved with preventative care and outreach to patients in more remote locations. This is another example of what we've produced in terms of reports for the government. This is an example of variation in care across the province. The LHINs, the Local Health Integrative Networks, there's 12 of them in the province who are tasked with providing and planning the healthcare system regionally. So there are 12 different regions in the province which are administrated by different LHINs. And you can see that there was a very wide variety of care being provided after discharge for patients for depression. A wide variety of access to psychiatrists, a wide variety of different types of care being provided by general practitioners, and post-discharge physician visits. So this is an example of the type of report we produce for the government. As part of our research sort of appointment at ISIS, we're also often asked to produce atlases. which is really aimed at policymakers, the government, politicians, as well as the public, to show people what exactly is going on with the healthcare system in Ontario. And there's been a wide variety of types of atlases being produced by ISIS for people in Ontario, as well as investigative reports funded by the province to look at exactly what's happening with a specific disease or a specific group of patients. And that's really been the goal of the research we've done in IBD, was to really describe how patients are being cared for and shine the light on IBD and pediatric IBD in the province. This is a disease that really has been fairly ignored, despite its high prevalence, by provincial governments in Canada in favor of other more high-profile diseases like asthma, like diabetes. So we really want to sort of start describing as to how care is being provided in the province of patients with IBD. This is an example of one of the studies that we produced, showing that there was a disparity between low and high-income children with Crohn's disease in terms of the risk of surgery, thinking that, again, Canada is a universal healthcare system, so the type of care that you're being provided should not depend on the income of the family. In fact, it does, and unfortunately, the gap is widening. So if you look at the hazard of undergoing intestinal resection, intra-abdominal surgery in a child with Crohn's, the risk is actually higher if you're low income after the year 2000. And this may speak to the access to the newer medications, immunomodulators, and biologics, which we had difficulty obtaining funding for in low-income patients who were on government-funded prescription plans. In addition, we were able to describe a very low rate of influenza immunization in children with IBD recently. But on the bright side, what we found, and this is a self-controlled case series study where we compared children who got the immunization in a given year to children, the same children, in years that they didn't. So we compared a risk period to a control period in the same children. And what we were really trying to assess was there an increased risk of IBD flaring after you got the influenza vaccine? There were some case reports in the literature. Not only did we find that there was no risk for hospitalization or emergency department visits in the period after getting the influenza vaccine, we actually found that in the 6 months after getting the influenza vaccine, you had a lower rate of needing to see your physician compared to years where you did not get the influenza vaccine. So there may be, and this is really, we used health services access and usage as a proxy for, IBD activity, but there may be a protective effect of getting the influenza vaccine in the years that the patients got it compared to the control periods. And this was adjusted for the season to which the vaccine was given. So that all led to a nice report from the provincial government, finally acknowledging IBD, and specifically pediatric IBD, as a growing area of need in the province, which is something that we haven't yet achieved. Not sure that it resulted in more funding towards IBD, it probably didn't, but the first step is acknowledgement that there's a problem, and as we raise awareness, hopefully that will bring attention to the IBD care provided to patients. So lesson number one from all of this that I've learned and that I'm hoping to convey is that when you assess a study using health admin data, think about how the results can be used to advocate for your patients and to advocate to policymakers. Really, the purpose of health services research is to improve care, but it's also to improve the healthcare system. And that goes for planning as well. So how, when you design a study, design studies with health services research in mind that you can try to improve the healthcare system. So going back to the cohort of IBD patients, one of the goals of that study published in Gut was to develop an algorithm to identify patients with childhood onset IBD within Ontario's health administrative databases. And an algorithm is really, it's like a diagnostic test where it's a combination of codes, whether it's physician billing codes, procedure codes, discharge codes, which accurately identify patients with IBD within a very large database. Just like a diagnostic test would accurately identify a patient as having IBD, this is kind of a diagnostic test that accurately classifies a patient as having IBD or not. And the diagnostic codes we used were the ICD-9 and 10 codes for IBD, which you all know of. Every physician bill is attached one diagnostic code. Every hospitalization is attached 20 diagnostic codes with different rankings based on importance. So we're able to see exactly what diagnoses are being assigned by physicians and in hospitals for each of the patients. And a few diagnostic algorithms have been described in the literature. The first was from Manitoba by Charles Bernstein's group, which found that patients required 5 healthcare contacts or admissions within an 11-year time period to accurately be classified as having IBD. So, you know, it's a chronic disease. Having one code was not enough. You had to have this combination of codes to be certain that you had the IBD. And with this, he applied this algorithm to Manitoba as well as to 4 other provinces. Ontario wasn't one of them at the time, to describe the very high prevalence of IBD in Canada. More recently, Kaiser Permanente researchers in Northern California found that patients required 2 healthcare contacts within 10 years to accurately be classified as IBD. So very different from the Manitoba algorithm. And even more recently than that, in Alberta, you required a different algorithm to accurately be classified as having IBD. And these were primarily validated in adult patients. So the bottom line from this is that, you know, there are different algorithms around the world, and which one should we apply to Ontario, and especially which one should we apply to Ontario pediatric patients, we didn't know. So we wanted to assess our own algorithm. And so just like a diagnostic test, to validate an algorithm, you need a group of true positive reference standard patients and a group of true negative reference standard patients. So for the true positive reference standard group, we took the Sick Kids IBD database from the Hospital for Sick Children in Toronto, which between 91 and 95 were thought to contain all pediatric patients under the age of 15 with IBD, because there were no community pediatric gastroenterologists at the time treating children in Toronto. So all children with IBD should have been seen at the Hospital for Sick Children. And we can talk about whether that was true or not later, but that's the assumption that we made. We linked their health card number to the provincial health administrative data. So there were about 183 children with IBD who were identified at the time. And we thought that, well, so if everybody was being seen at the Sick Kids, in the Sick Kids database who had IBD within the city of Toronto, everybody who wasn't contained within the Sick Kids IBD database but lived in the city of Toronto at that time was thought not to have IBD, and therefore became the true negative reference standard patients. So there were about 936,000 children living in the city of Toronto at the time. So the first thing that we found, that having any one code for IBD, so either an outpatient physician visit or a hospitalization with an assigned diagnostic code for IBD, Crohn's or ulcerative colitis, had a very high sensitivity and a very high specificity, but you can see that the positive predictive value was extremely low, only 7.9%. So that meant that for 183 children who truly had IBD in the database, there were over 2,000 patients who were false positives, who had a code for IBD, but were not in the Sick Kids IBD database. You know, these patients may be patients who had self-limited colitis, infectious colitis, other things, who were coded by someone as ulcerative colitis or Crohn's, and it resolved, and they never had another code after that. So clearly one code was not accurate at identifying and classifying patients with IBD. So we constructed over 1,000 different 2x2 tables, and you remember, just like a diagnostic test, you construct 2x2 tables to define sensitivity, specificity, positive predictive value, negative predictive value, and these are examples of, you know, the different 2x2 tables we constructed. And I just want to bring your attention to the bottom one, 5 outpatient visits or hospitalizations within 10 years. So this is really the Manitoba algorithm as best as we could approximate it. This is the algorithm from Manitoba, and you can see that the positive predictive value in children under 15 was only about 50%, so not really adequate for the pediatric group. When you look at patients under 12, that subgroup of younger children, the positive predictive value went up to 63%, 64%. So that's sort of lesson number 2 of all of this, is that algorithms validated and created in one age group may not necessarily apply to others, and you need to try to validate and look at how the algorithm is functioning in the age group to which you want to apply it. So without going through all the details of the algorithm validation, in the end we found that the best algorithm for the pediatric Ontario population was a 2-step algorithm defined by whether or not a patient underwent endoscopy. So if they were scoped, if they had a sigmoidoscopy or colonoscopy, we were more certain of the diagnosis, so they required 4 contacts, outpatient contacts, or 2 hospitalizations within a 3-year time period, so a much shorter time period to fit the pediatric, you know, age group. If they were not scoped, if they were never scoped, which is a fairly small number, we were less certain of the diagnosis, so they required more contacts to be certain that we were classifying them correctly. And this functioned fairly well in patients under 12 using the Sick Kids IBD database as the reference standard with a positive predictive value of about 75%. And then we validated, we didn't want to say, you know, well, Sick Kids database, that's good enough to apply it to the whole province. We wanted to validate to see whether the algorithm worked across the province in a variety of different practice types. So community gastroenterologists, adult gastroenterologists, seeing children, and also looking at patients under the age of 18, not just under the age of 12 or 15. And so we extracted the charts from different practices across the province, about 1,800 charts, and we found that this pediatric algorithm that we created functioned extremely well across the province. More recently, we wanted to look at an adult-focused algorithm, again thinking that, yes, we could just apply the Manitoba algorithm or the Alberta algorithm to Ontario, but maybe we should make sure that it functions well in Ontario. So we used very similar methods. We took adults above the age of 18 as a cutoff at diagnosis, and we used the Ottawa Hospital Data Warehouse. So the Ottawa Hospital is a very large, one of the largest tertiary care centers in Canada, comprising 3 campuses, and they database all contacts with all patients in the Ottawa Hospital Data Warehouse. And not only do they contain contacts like the health administrative data, but they have a certain amount of clinical data as well. They have pathology reports, radiology reports, prescriptions, inpatient, outpatient visits. They have some laboratory results as well. So a very well-designed, you know, database of clinical and admin data that you can link to province-wide data. So we searched patients for all suspected cases of IBD, and we defined that as anybody who had a single code, admin data code, outpatient or inpatient. Remember that in pediatrics, that sensitivity was about 99.5%, so that should capture the vast majority. But we didn't stop there. We said, well, any code or any reference to IBD, Crohn's, or colitis within a radiology report or within a pathology report. So we really tried to expand the search to include many different areas of search. And we found that by doing that, there were about 1,750, within a 5-year time period, 1,750 patients with IBD who were seen at the hospital. Of those, 554 were incident cases, which acted as our true positive reference standard. Of the ones who were searched, there were 3,300 patients who didn't have IBD. We couldn't confirm any sign of IBD whatsoever, so there may have been a reference in the radiology report that says, you know, could not rule out IBD or suspecting IBD, but there was no confirmation after that, you know, on scope or pathology or whatever, that there was any IBD. So we use those patients as a true negative reference standard patients. And then once again, we validated across the province in community gastroenterologists, other tertiary care centers across the province, and extracted their charts to act as true positive and true negative reference standards. So again, constructed lots of different 2x2 tables, but this table is just to bring to your attention that we compared different algorithms that had previously been published. And the first thing to note is that the different algorithms previously published functioned very differently. So once again, just having one contact, outpatient or hospitalization, did not function very well. The positive predictive value was only about 50%. So, you know, one of the lessons to learn is that, you know, when you read all those studies that say they assessed hospitalizations in patients with IBD who had one contact for IBD and that was it, you have to wonder how much false positive rate there is in there and how many patients who don't have IBD contaminated their cohort. But you can see that the sensitivities and the positive predictive values varied depending on the algorithm. So the Ontario pediatric algorithm that I showed before and the Manitoba algorithm functioned fairly well and fairly similarly, but the Alberta algorithm didn't function quite as well in Ontario, and the Kaiser Permanente algorithm did not function as well as the others. So a very wide variety of different algorithms, how they functioned in our Ontario population. So lesson 3 of all of this is that algorithms validated in one jurisdiction may not necessarily apply to others. You really need to revalidate and see how the algorithm is working in identifying your patients, or you may risk contaminating your sample with patients that you don't want to look at. We also, using the adult databases, looked at different age groups. So remembering that the pediatric age group, you know, the adult algorithm didn't function very well, we wanted to look at how did it function in different adult age groups. And specifically, we looked at patients 18 to 64 at diagnosis compared to patients who were over 65, elderly patients at diagnosis. And I apologize for the use of elderly for anybody in the room who's over 65, but that's the legal definition in Ontario for elderly. But you can see that the Manitoba algorithm, which is the one that we ended up going with for the adult group, the Manitoba algorithm functioned very differently in adults 18 to 64 compared to those above the age of 65, with different positive predictive value and sensitivity. So we weren't satisfied to say that the adult algorithm would function well enough in elderly patients. We felt that we could make it better. And remember that Ontario has good drug data, full drug data for patients over 65. So we wanted to look at how the algorithm would function if you added a medication claim for an IBD-related medication. And in fact, the positive predictive value went up without much sacrificing of the sensitivity. The sensitivity was pretty good in the validation cohort as well. When we excluded 5-ASAs, thinking that 5-ASAs may be used in microscopic colitis or other, non-chronic IBD patients, unfortunately, while the positive predictive value went up a little bit, the sensitivity dropped very significantly. So we decided to go with, for the elderly cohort, the Manitoba algorithm plus a claim for an IBD-related medication, including 5-ASAs as the final algorithm. Yes, we have complete medication data for patients over 65. Yeah, I'd love to know how it would work adding a medication for 18 to 64-year-olds, or especially for the pediatrics, because I guarantee you there's... What's that? Yeah, exactly. You know what? You guys have much better data, and Manitoba has better data, but they haven't looked at that yet. I suspect for pediatrics, adding a medication claim will make the algorithm much, much more accurate, because there are very few children not on a medication for IBD. So, again, that brings us back to the idea that you really need to validate in different age groups and not assume that your algorithm works across all age groups and across all jurisdictions. Well, predictive values will depend on the prevalence of the disease in your validation cohort. And if you quote a predictive value with a high prevalence disease cohort, so if you've got 9 patients with IBD for every 1 without IBD negative, it's not going to the PPV will look falsely elevated, and it may function very differently when you apply it to a database of a low prevalence population where IBD is 1 in 200, let's say. So when you're quoting PPV and NPV, the prevalence of the disease in the validation cohort should be approximately the same as the prevalence of the disease in the population. And of those studies that reported PPV or NPV, only about a third made sure that the prevalence of the disease in the validation cohort was the same in the population to which it was applied. And only about a third reported 95% confidence intervals for their diagnostic accuracies. So there was lots more that we reported, that we found that reporting was good, like the introduction and the discussion and things like that. I didn't talk about that. But basically, the bottom line here is that we can do better. We can do better with reporting of studies. We can do better with our methods, and we're improving all the time. So with that in mind, we did the study for reporting of algorithm validation studies, but we've now linked with an international consortium called the RECORD Consortium, reporting of studies conducted using observational routinely collected data, which started really from 2 separate groups, one in Canada, led by ISIS, and one in the UK, led by the London School of Hygiene, who both wanted to produce reporting guidelines. We wanted to do it for admin data research. They wanted to do it for their primary care databases, like the GPRD. And basically, we approached STROBE, the standards of reporting for observational research, so the STROBE criteria. We approached that STROBE group separately and said, well, does STROBE want to collaborate with us to produce reporting guidelines separately? And they said, well, wait a second, you guys there's a lot of overlap between primary care databases and admin data. Why don't you join? And in the end, we ended up with a large international consortium to produce reporting guidelines for all observational routinely collected health data. So primary care, registries, whatever type of database you can think of that's not with an a priori research question in mind ahead of time. And this is really funded internationally as well. CIHR is the primary funder, the Canadian Institute for Health Research. But we've also gotten funds from the Swiss National Science Foundation and from Aarhus University in Denmark. Part of that was we're conducting surveys of stakeholders. So this is already finished, but we sent out a general call for stakeholders, and this includes researchers who use these data, as well as people who base their decisions on these data. So clinicians, policymakers who often base their decisions on health services research, pharmaceutical industries who often use the data to make decisions. So we sent out a general call and produced a couple of editorials, and we got quite a few responses. And we conducted a survey in 2 stages. The first was an open text survey with qualitative analysis to see what stakeholders felt was important to include in these reporting guidelines. And the second, we went back to them and discussed the themes and asked them to rank them in terms of importance, with the goal of trying to cover everything that people felt was important. And so the participation was really international from around the world as best as we can muster. And these are the themes that people felt were important to report in studies so that there was transparent assessment of bias and assessment of the results were all transparent. But it kind of gives you an indication of what people feel is important in the methodology as well, not just in the reporting. And you can see that the number 1 and 5 most important things were things that I've just discussed with you. The disease and exposure identification algorithms came out as number 1, as most important, that people need to be transparent in their reporting, but also how valid the diagnostic codes are. So really the validation of diagnostic codes, not just with the identification of patients, but with exposures, with outcomes, with confounders. People felt that it was important to report whether these codes were validated or not, and in what way they were validated. You can get a sense for the other issues that were important to people, the characteristics of who's in the databases. So that's important for you here, where you've got 4 Kupat Cholim, where the populations may be different in systemic ways. You need to report what kind of patients are included in the databases before you conduct research, so that you know whether it's generalizable to the population that the reader is interested in. Characteristics of the data. Linkage is becoming a bigger and bigger issue. As we're able to link between databases, we talked about linking between our admin data and the immigration data. There's error that's introduced if you're not able to do a deterministic linkage with a number. So I've just come back actually from Lausanne last week, where the working committee met, 15 researchers from across 7 countries, including 3 journal editors, BMJ, PLOS Medicine, and CMAJ, and we've produced the draft reporting guidelines, which I'm going to spend the next 6 months probably writing up and making into clear language. But the goal will be that these draft guidelines will be on a website for stakeholders to comment on and to assess and rank and make sure that the stakeholders are satisfied with what we've covered, which was all based on the stakeholder survey in the first place, but we really want to go back and get another reassessment. And hopefully in the next little while you'll start to see that on this website. Right now the website links to the Equator Network website, which is the network of people interested in reporting guidelines of all different sorts. You'll see a little bit of a methodology of record on the website now, but we're planning on in the next month or so producing a unique website that'll have a social component to produce, to get feedback on the reporting guidelines. So, in conclusion, algorithm validation is important. I hope I've stressed that enough, that you really need to validate carefully, and you need to validate in different subgroups based on age, region, healthcare system, whatever you think might be different, systematically different between subgroups, it really should be validated. And it's not enough to say they have one code, they have the disease. And the methods are evolving, I think, in general. There's not great reporting of algorithm validation studies so far, and this has emphasized the need for good reporting guidelines to making sure that all the biases and the methods are transparent and people can assess the literature very transparently. And in general, we're early years, right? These administrative databases and the ability to analyze these databases, the computing power has only recently been established, and the methods are changing. The methods are improving as we go. So I'm not casting judgment on studies that were done in 1995 using these databases. That's what we knew then. And just like clinical trials and observational research, we're developing the methods. And I think contributing to the developing methods of these databases are really one of my goals, and should be one of the goals of all researchers who conduct this type of research. And again, thank you to all the collaborators and sponsors. What's that?
Do you ever sleep?
Do I ever sleep? Yeah, I do.
So
2 by 2 tables. So when we approached Lilith or Moshe Becca and other people as well, they said, why are you doing this specifically? So now computerized software that will do decision analysis for you, that will take all the different aspects and they will play around with the data and will just give you the 2 or 3 best algorithms.
Okay, so this is a long discussion that we had actually last week at the record meeting. And the question is, and it's not only for the algorithm identification algorithms, it's also for risk prediction models. And there are all sorts of prediction models that are available commercially in the United States primarily, where you apply it to your data and you can, predict the risk or predict how good your care was. And many of these are proprietary. They're not shared and they're not published. And it was a fairly long discussion, but the bottom line is that the record group will be putting into place that we recommend the reporting of all the prediction models and exactly the methods that were used to derive them, and that includes the algorithm and all the raw data to assess whether it truly is the best model, and that this should be published in an online supplement when you publish the journal article. And if that's not available because it's proprietary or it's copyrighted or whatever, that should be explained in the article. So it's, it's not to say that you can't do that. Certainly you can, but I think it's up to the reader to decide whether that's sufficient to assess the risk of bias and whether it truly is the right algorithm. And I think readers are becoming more careful, and so are journal editors, in wanting to know all of the information before accepting the algorithm or the validation or the risk prediction model.
Do you feel that mathematically derived algorithm could be a good substitute?
I think it's possible. I think it's certainly possible. There's been people who have done that. There have been people who have no gold standard who have used Bayesian techniques to produce algorithms. I think I've never quite grasped Bayesian statistics. It's very hard for me to understand, and I don't know whether that's accurate or not, but I think it's possible that it is, and I think transparent reporting is very important, right? So, let the editors, let the statisticians who know these areas assess. Certainly, like I mentioned, a lot of algorithms are looking at area under the ROC curve and using logistic regression to produce, risk of misclassification. Basically, that's what it is, right? Equations that assess the risk of misclassification. And in fact, what may be most accurate is that you have different algorithms depending on what question you're asking. So maybe you want one algorithm if you want to very much minimize the false positive rate and you don't care if you're picking up everybody, versus another algorithm where you want to get everybody and the false positive rate is not as important. You may want different algorithms. So that's all in evolution. I think, I'm not going to cast judgment on whether it's right or not, but I think transparent reporting is extremely important, and not necessarily taking everything at face value and validating in different age groups, different subgroups, different jurisdictions is really important.
Patients with mild disease. You need only probably one physician contact, and you get 100% positive predictive value for a patient with enterovesicular fistula, underwent 2 surgical intervention, etc., etc. So I don't see any of those algorithms, any reference which is probably problematic to the severity of disease and the nature of contacts with physicians.
Yeah.
One contact during surgical intervention, for instance, is totally different than someone being sick in a community clinic.
Yeah.
Furthermore, even most of the validation cohorts are tertiary hospital records, as you just showed, right? Toronto, Ottawa Center, etc.
No. So that's why we validated elsewhere. So we went into community practices as well as tertiary care centers, and we went to general pediatrics and family physicians' offices as well. So it wasn't just, the initial algorithm development sample, which were the numbers on the left, was the tertiary care center compared to that population, but the validation sample was across the province. So we certainly did look for both pediatric and adults how the algorithm functioned in community practices compared to tertiary care centers, and it functioned very well in both.
Is there any allowance for severity of disease?
Yeah. So unfortunately not. This was Yeah, I mean, you're absolutely right. That's a weakness of this validation research is, you know, for feasibility reasons, it's very difficult to define severity of disease. So do you define it based on the first few months? Do you define it based on all the follow-up data available? And then how do you define it? Do you do CVAI? Do you do PCDAI? Do you, you know, it was too controversial and too subject to problems to go into that at that point. Additionally, feasibility-wise, you know, chart extraction would take a lot longer and you can't do as many charts. So we made the decision to sacrifice that. That being said, validating in those subgroups still extremely important. I think that's something we absolutely have to look at. We sort of made the decision that we wanted to get a cohort together that was representative of the full population. So you're right that we're probably missing, you know, some patients who were very mild, who saw the physician only a couple of times and then disappeared. But you know, the sensitivity was still very good, so we made that call of leaving it. But you're absolutely right.
Eric, for our purposes, I think that this can only be prospective chart view of capturing data, because if you're missing the dates, which is going to be iron-cast evidence that something was done SAMI equation, treatment was commenced or stopped. If we're lacking the dates, which is what happened when you view charts retrospectively, then we're missing the point.
So why do you say you're missing the dates?
Demographics is something that would be relatively easy to capture here.
Yeah.
With our systems. Correlation to clinical details would probably also be relatively easy because we have good EMRs, at least in
Yeah.
the this is what I'm familiar with. But if we're not correlating that in a prospective manner to reflect progression of disease based on, let's say, standardized monitor classification or the IBD Genetic Consortium manual, so standardized. These would not be prospective data capturing and then we need to have relation to dates when changes were done, how disease has progressed, otherwise retrospective looking at that
Yeah.
underestimation or missing.
So I mean, you would have the date of the diagnosis, and you would have whether or not the patient had the IBD.
That's demographics.
Yeah, yeah. It's not. You're right. I mean, I think again, like I said, that's sort of the holy grail is to have prospective, clinically collected data or good retrospective data if you have a standardized way of doing it, and linking that to the admin data so that you never lose patients. They're never lost to follow-up, which is the risk in a clinical cohort that you lose them. Absolutely, I agree. And I think on a macro level, on a big level, you can describe what's actually happening with these patients without having the clinical information. You can describe important things like their outcomes, whether there's disparities in care, whether there's variation in care on a macro level for all the patients. You're right, clinical data would be very useful.
I want to
Yeah.
the issue of incident cases versus old cases that now coming into your system.
Yeah. So I didn't go into that for this talk.
We had some kind of puzzling issue because we had in 2003 or something like this massive income of new cases, so-called, into our system. So what is your experience with this kind of?
Yeah, we call that a look back or a washout of prevalent cases. So what we did in the pediatric group is we wanted to assess, so the validation cohort was incident cases. So the algorithm was aimed at incident cases. But you're right that at some point, a child who flares will have that, who already had IBD 10 years earlier, will have that combination of codes. So we looked to see, in the chart extraction, we also looked at prevalent cases in the community extraction that we did, and we found that if they had no codes, no healthcare contacts for 3 years prior to that first contact, that we were 95% sure that they did not have IBD before that they were not prevalent cases. And that's why our incident cohort starts in 94, because we have data, complete data, admin data from 91 onward. So the pediatric cohort starts in 94. Now, adults is a completely different thing, and we recognize that because when I was reviewing charts of adult patients, there were patients who had apparently Crohn's, diagnosed 20 years ago and had a flare but hadn't had any symptoms or any medications for 10 years. And so what we found, again, doing the same methods, is that the look-back period for adults needed to be 8 years, not 3 years. So if they didn't have a code for 8 years prior to that first code in our data, they were likely to be incident cases and not prevalent, with 95% sure that they were likely. There were still 5% who had no codes for 8 years and truly did have Crohn's or IBD. And, you know, we made that decision that 8 years. So our incident adult cohort starts in 1999 because you needed that 8-year look-back period. So that becomes difficult if you only have data starting in 2001 or 2003, yeah. And that's something that hasn't been addressed by the Manitoba or the Alberta algorithm. They were looking at just prevalent cases. And so when you see that rise gradually, you know, is that just the new prevalent cases, or is that really a rise in IBD? For us,
can you improve that if you link it to endoscopy or imaging? The first one is usually after at least imaging.
Well, I don't know, right? If an adult patient comes to you after 10 years and has a flare, do you not scope them? Often we will, right? We'll make sure that this isn't C. diff, it's not CMV, it's not whatever. You know, if they haven't had a scope in 20 years, they're going to get a scope. So I'm not sure. We didn't look at whether a scope would be able to better differentiate that, but I'm not sure that it would, right? And
it's the first one ever. It's easy for you to
but again, we only have data from 91. So how do you know it's the first one ever, right? How do you know that they didn't have another scope in 1988 and we just don't have that information? So.
Thank you. I think unless we want to go beyond, fine with me, but
you're the chairman.
you're the boss, though.
Well, again, I'm happy to chat with people afterwards. You know, I'm here. I'm here all week, so.
Thank you very much.
Thank you.
Okay, just a final word. I want to say people who stayed to the end know already that we are trying to do something like that now in the 4 HMOs, and I think without going into details, I do want to say 3 sentences. One, this is a unique opportunity to collaborate and to do something really exciting in Israel on a national base scale. It's already the linking of all large hospitals that we already networking and sharing information is already very interesting. And if we can, what seems to be that we can expand that also to the 4 HMOs together, so we do have an amazing network of all hospitals and large community clinics with the HMOs will be a resource that potentially will be more provide more data than even what Eric is doing in Canada or what our friends are doing in Scandinavia, because we do have a potential by the nature of how it works and structures to do some things that are very exciting. I did all this is just to say the final word, that this is an open collaboration, and if someone wants to share, and if someone wants to contribute, and if someone wants to be part of it in any way, so this needs to be a collaborative effort that is open for everybody, and each one in their own expertise and option. I think there is room for everybody to contribute, and I think this needs to be the strong message across the institutions and the organizations. So with that, thank you very much for the speakers and for the chair people, and again for the organizers, Malka, Gili, Tamar, and Leah. You've done an amazing job. Thank you very much. And you're all invited to lunch just across the hall in the GI conference room. Thank you.